Good evening, everybody. This is Dr. Apoor Mehra, and we welcome you to Cerebellum Academy YouTube live discussion of INI CET exam. And
Real life now.
with me is Dr.
This
Sparsh
is
Gupta.
Dr. Apoor Mehra, and we welcome you.
स्पर्श वो तेरा ऑन होगा ना वो ऑन हो गया होगा तेरा यार
No
so
worries.
we have Dr. Sparsh Gupta sir and Dr. Praveen Tripathi sir discussing the important aspects of the paper. So Dr. Praveen, as we were discussing, can you just give an idea about what feedback you have got from the students till now?
Right, sir. Good evening, Apoor sir. Good evening, Sparsh sir. Hello, students. All of us have been talking with the students who appeared for the exam, and there are certain initial trends that we are getting, sir. So one is that, this is something that students are saying repeatedly, that it appears less of an INI CET type of exam, more of a NEET PG type of exam. So when we ask them to actually elaborate what do they mean by that, so what they are saying is the number of clinical questions, long clinical vignettes, such questions were lesser. They were there. They were like 10 to 20% of the questions, but more questions were fact-based. So that is the first things per sure that I have gotten from the students. And I think on YouTube, we can see the comments. Students, please do tell us what you feel. And the second thing that the students have been saying is that the paper was not difficult, it was moderate as far as the difficulty level is concerned. So after the NEET PG, a lot of students said that the paper was very difficult. This time students are saying it was moderate. And the third thing, sir, this is something that I also asked in our Telegram group. How many PYQs, PYTs were there? So apparently exact repeat of PYQs was not there. There were not many exact repeats, but modified PYQs and PYTs again form like 50 to 60% of the paper, or maybe slightly more than that. These are the first three things that I have gotten from the student. Some students have said that the third module or the third part of the paper was slightly tricky. But let's find out. So students, we are looking at your YouTube comments also. Okay, many students are saying looks easy, but it is not. Yeah, I saw a very good comment from another student of our Telegram group. He said that at the first impression is that it was an easy paper. But when you look at the options, then it does not appear to be so easy because you were able to rule out two options, but the remaining two options were quite tricky. So it might appear to be an easy paper, but when you look at the options, it was not that easy. It was moderate at best. And this is what students are also saying. And
if you look at the trends, Dr. Praveen,
right, sir.
the first time तो कोई भी बाहर निकलता है वो यही कहता है आसान था.
हाँ.
Right?
Absolutely.
Somebody is saying that in entrance exam, in Indian entrance exam, especially INI, it's easier. So समझ नहीं आया. In the first exam I gave, in which I did not clear, this was the feeling I had.
Yeah.
Actually, it's not that difficult as paper 2 of NEET this time, the way it was. But because there things were not heard of, here things are more heard of.
Right.
As you just mentioned, PYQ and PYT, not exact questions, but lookalike were there, so they feel easy. But
Yeah.
I will give you two examples in the questions I have got for ortho, how they tricked the students. So this is the first impression. Second, there were certain subjects which normally they were skewed towards four subjects. They said a lot of questions came from ENT and ophtha.
Right.
Right, and a lot of questions came from micro and forensics. So this is what students have written to us personally.
Right.
Right, but I know that as the day will go, as the sun will set, we will start seeing other subjects which they didn't notice.
Right.
What we remember in the exam when we give an exam is the questions we've got stuck at. So it appears those subjects are more.
Right.
When you come back. And the some of the questions which are very natural to you, they come easy to you. So you don't remember much, but as they will pen down all the questions, I am sure they will realize that yes, the skewed thing was there, but all the subjects were there. Maybe the distribution changed a little. You were about to say something.
But sir, Ophthal and ENT being asked more and forensic being asked more is something that has not happened in last 5-6 years at least. So this is something new. A lot of Ophthal question, a lot of ENT question, a lot of forensic question. And the psychiatry was not there. There was just one question. Dermatology, I think there was only a question or so. So yeah, the paper was not really well distributed. That is for sure. Sparsha, your inputs, please.
Hi, good evening, everyone. So, sir, I would like to add upon, something which I personally call by the name of a recall bias. And that is just what Apur sir just made a mention of. So, two sets of questions which will always be recalled by students. One, which they have repeatedly studied, right? So, they have a natural tendency to, recall those questions and have a feeling कि यार ये बहुत आसान था. And the second is questions which you find very, very tricky because you had just absolutely no idea about what is he asking you in the exam.
Correct.
Right. And the other thing, as Praveen sir is making a mention of, is that, some questions, some subjects were not asked, that importantly, or as was the trend. But this is how they are likely to kind of, make the things unpredictable for you in the exam.
Yeah.
So, there were syndromes in which there were certain options changed, extended master following questions were there. I was surprised to see that, image-based questions, which were quite atypical in the sense that in my subject, say, for example, flow cytometry graphs were there. Even the questions were, quite decodable, but it was a new trend. So the AIMS always will take the pride in the fact, just like a UPSC paper. So I also remember my UPSC, first time I, appeared in the exam, it was way too easy. That's what I told my friends. And that's why I was not selected. Right. But when I gave my actual attempt, that was the internship attempt, and post that, then I found the paper to be really beautiful. I found that topics were there, but then, they kind of tricked a lot of people into marking the wrong answers. So as and when we start off with the discussion, we proceed further for our discussion, we'll realize that I would be rather cautious in saying the word. I can't say the paper was easy. Of course, I would say that, what happens is that with something like Cerebellum, you are having a look at the videos once. Then somebody like Praveen sir and Apur sir ensure that we have a revision class. Then we have a third revision. Then we have a marathon. So as teachers and as students, when you are attending the program sincerely, you are at least reading the important facts 3 or 4 times. That is what is making the things easier for you in comparison to other people. So I would be rather cautious in saying that the paper was easy. I would rather say that it is your effort which made it appear easy. And of course, as and when we progress, we'll find exactly how were the questions and maybe some of the options that a lot of people can give their input about it.
And what I see here, Dr. Praveen, is they are saying lot of anat came, lot of physio came, path was there, micro was there. So first, second prof was huge.
Right. Right.
Pharma was a little tougher side. That's what they have mentioned. Biochemistry was in atypical for INI CET. This is what they say.
Right.
As more of feedback come, Dr. Praveen, let me take the privilege of just discussing 4 questions which I have.
Right.
I have a simple 4 lines. I'll put a detailed discussion later on in the app.
Right.
We had one classical question that keeps on coming is ankylosing spondylitis.
Right.
And we always talk about sacroiliitis in a young man with anterior uveitis. So this was one question that came on ankylosing spondylitis. All right, this is one thing which you should always remember. If it is sacroiliitis young man, it has to be ankylosing spondylitis. The second question that came was very good. If you have a radial nerve palsy, you normally have a wrist drop, but this time they changed it to posterior tortious nerve palsy around the head of radius, causing finger drop. This is loss of MCP extension, finger drop. So they had asked this question. Now students are writing different examples, like they had mentioned radial nerve palsy, posterior tortious nerve palsy. So हमने जो मार्क किया हमको वो दिख रहा है. But majority have said it was about posterior tortious nerve palsy. So the second question that we have. Then we had a question that fracture neck of femur management in a young man or a female, 45-year-old female. And the management is simple, close reduction because it is an extra-articular fracture with internal fixation. So this was an option which was there. If the same thing comes in more than 65 years of age, we will do hemiarthroplasty, which was asked in last INI CET. But again, they are in love. They asked 3 questions on femur. And the fourth question, which the debate is going on, you go to Telegram groups, you go to all the WhatsApp groups. The fourth question was they had shown 3 bones where they had shown multiple lesions. Another version of this question is only 1 bone, a hip joint was destroyed shown. So if they show you a destroyed hip joint, it is going to be tubercular hip. If they show multiple bones with multiple lesions, then you have to think about a pathological lesion like metastasis. So in orthopedics, they gave you 4 questions. For me, if I see fracture neck of femur and ankylosing spondylitis are 2 questions which are normal. They come. Third is the management of fracture neck of femur age-wise. It has always been called an unsolved fracture. So it is always going to be into a debate. And posterior interosseous nerve palsy causing finger drop is something you will have to remember it. We have been doing it in the cerebellum live sessions multiple times. We did it in marathon. We did it multiple times. This is something that you should get onto. And the fourth question is, as we get more details, there were 3 images or 1 hip images that we'll come to know in the future. So
So
this
sir,
is
out of these four, how many would you call as PYTs?
yeah. So ankylosing spondylitis, sacroiliitis, anterioritis, तो नींद में भी PYT है.
हाँ, ये तो
PYT,
बहुत
PYQ
कॉमन
है.
है.
ठीक है?
Right.
Extracapsular fracture neck femur is a repeated topic from previous INI CET.
Okay.
There were 3 questions on neck femur and femur, femur, femur. So it was there. And
Okay.
you just had to write down the answer where internal fixation was mentioned. So
And one was a new question.
right. So these two,
Hmm.
posterior interosseous nerve, palsy causing finger drop is a PYT.
Okay.
And the fourth question, we don't know what it was, but yes, I will label it as a new question if they have shown multiple bones with lighting. So
Right.
the orthopedics is a difficult subject, Dr. Praveen, as we understand. If you are able to get 3 out of 4, I think that's huge. That's what I take my call on. So this is what I say. And as you take your questions, I will read on the comments.
Right.
Absolutely.
Looks like there were a lot of new questions from pharmacology. What students are writing appears that a lot of new questions from pharmacology. Anyways, so can I discuss the only psychiatry question? And students, please stop taunting me. I know there were not many questions from psychiatry, but 10 बार लिखने की जरूरत नहीं है कि psychiatry से ज्यादा नहीं आया. ठीक है? समझ गया मैं ज्यादा नहीं आया. All right. So this is the question. So I'm going to consider it as 4 questions. So, I mean, it's a very easy question. I'm sure everybody would have gotten it correct. And at least for psychiatry, every single teacher would have 100% strike rate because it's like a question, which is very easy. So, this was the question, sir. Can you, it's visible on my screen, but all right. All right. चलिए. So match the following. Basically, they wanted you to match the drug of choice with the clinical condition. So delirium tremens, of course, oxazepam. A3, opioid overdosage, naloxone. B2, alcohol dependence. For relapse prevention, we have a acamprosate. Sorry, B4.
B4, sir.
C2, alcohol dependence with acamprosate and smoking cessation with varenicline. D1. So A3, B4, C2, D1. Answer is C. And I think it's a very simple question. Everybody would have gotten it correct. So, sir, that's it.
I just wanted to add, Praveen sir, that your contribution with respect to the students is going to be much more or going beyond the number of questions that they will ever ask you in any exam. So Praveen sir, I would say, is the guy you go to when you are going to be appearing in the exam. Of course, for all the kind of mental health issues and beyond that as well. And of course, he is the backbone who ensures that we are going to be having not one, not two, but multiple revisions, as I said time and again. Now, so
Thank
far
you for
as
Before you
Thank you for your
start,
sympathy,
Dr.
sir.
Bhatt,
Thank you for your sympathy.
no sympathy is there. You have a bigger, Praveen, you are beyond subject now.
बिल्कुल सर.
Your role into guiding students and cerebellum is beyond subject. So it is different level now.
ये ब्रेकअप होने का लड़का जब हॉस्टल में दोस्तों के पास आता है ना तो ऐसे बोलते नहीं नहीं तू तो बहुत ही अच्छा. ठीक है
पर
सर.
शेयर मत करना, कुछ बातें बोलनी है या जो मैं बच्चों की पढ़ रहा हूँ. I can see here that students are writing that आपकी 4 दिन की क्लास में से काफी क्वेश्चन आए. So students are thanking Dr. Sparsh for the same. There are lots of
Right.
anesthesia questions that students have mentioned. Anesthesia also was a lot of there. One tweet somebody has done right now, INI CET is the new NEET PG and NEET PG is the new INI CET. That is in the air. So that's how they are saying it like. ये सब students ने बोला इसलिए मुझ पे गुस्सा मत निकालना. This is something students have said. And yeah, that 45-year-old female was an intracapsular fracture neck of femur. So answer will be closed reduction plus internal fixation. As one of the students is saying, sir, मैंने wrist drop mark किया, वो debate चलता रहेगा. And the last thing which I have been telling you, destroyed, if they have shown you destroyed hip, mark tuberculosis, if they are showing you multiple bone lesions, it is going to be a systemic disorder like metastasis. So this is what we have been telling, but we'll come to it. And Apoor sir, what is FRAX? We will talk about it. It is related to the fracture score for osteoporotic patients that you have to give me the question to answer that. Now I will go to the subject right? Recently, I was being interviewed by somebody. He asked me which is one book to read in MBBS, and my answer was Robbins. So let me take it to the person who's going to have a long PPT and have a long discussion with you, right? And the other institutes have started showing their PDFs. So Praveen sir, do you have PDFs to show what questions came in psychiatry? So that is something they want to ask.
Sir, I think the comments of the students of the fact that a lot of them were able to answer the questions right from the sessions that they have just attended in the previous 15 days is a testimony to the effort that the faculties have been putting in and equal amount of, the faith and the effort that students have been putting in the live sessions.
Yes, sir. So, the one thing that I want to say is, I mean, students are commenting also that this marathon thing that we do, revising the entire course in last 10 days, it appears to be, becoming very famous, and it is giving you a lot of questions in the exam. So last 7-10 days, it's always a question in your mind whether to revise your own notes, whether to go for marathon, whatever. It appears that marathon is proving very, very handy. So, after INI CET, many students would appear for NEET PG and FMJ also. I mean, separate set of students. So marathon is something, students, that you have to give importance to. It is adding many questions, many marks to your final score. All right, sir. Over to
Praveen, I have a
Dr.
question before Spurs starts.
Yes, sir.
Why was it named marathon? Why was it not called the sprint?
Sir, I called it, I mean, we called it marathon because, it would start at 9 a.m. in the morning and would continue for at least 10 hours or 11 hours and day after another.
Fantastic.
So, the fact that it would be very difficult to complete, and this is what we say in the beginning itself, that we are going to cover everything, but it's not going to be easy for you. So you'll have to be very disciplined. You'll have to be very motivated to complete all those 80 hours of lectures. So, sir, I mean, difficult to complete, relentless, continuing. So I think marathon would be a better word.
It also solved one problem. End में we get choked. पढ़ना क्या है?
Right.
अगर सामने बैठ के बोल रहा है उसको सुन लो. So Spurs, we have been stopping you twice. We have caused hindrance. So all the best, students, for your results. So I'll take your leave. All the best, Dr. Spurs. Thank you very much. Bye, Dr. Praveen. Tata.
Thank you, sir. Bye-bye.
Thank you so much, sir. So I'll just try to cut down the time the students are investing in this live session. So straight away going to the questions as much as I can recall with the options. So one question that was shared by a lot of you was about a 5-year-old child who was having the presence of a history of gum bleeding. Could not get the recall picture with regards to the peripheral smear image, but a lot of people were happy because we had a discussion about flow cytometry graph interpretation during our discussions of PNH, during our discussion of hyper IgM syndrome. And therefore, people said that, they could easily understand that this graph was showing you the presence of cells which were TDT positive. Of course, that would have been an indicator of the fact that we are dealing with something like a patient who's going to be having a, lymphoblast over there. And then it did have a second image of flow cytometry in which they could decode that the cells which were present in the patient was CD19, 20, and 22 positive. So obviously, this was a patient which was a patient of ALL. Considering age, the flow cytometry, and the marker that we are going to be having over here would be proving that we were having a patient who is going to be, B cell ALL. So not a difficult question, but yes, interpretation of the graphs was a challenge for the people who are encountering it for the first time, not for those who are attending the live sessions pretty regularly. This was a kind of repeat question wherein the patient had a history of a gastric surgery, and then patient had a decreased sensations. The patient was having the presence of a neuropathy-like manifestation, tingling. Some people, kind of confused it with the NEET question. People said Romberg sign also was mentioned. I'm not too sure whether it was an exact repeat, but of course, the kind of nutrient deficiency that you would expect in the patient was asked. So easy for you to decode that we were dealing with a patient suffering from B12 deficiency, right? Then we had a question which was about a patient who happened to be suffering from diabetes. And for the long-term glycemic control, we obviously going for something like HbA1c. But the question was asked about the anticoagulant that is being used over here. Now, this was a slightly, I would say, deviation in the sense that you had a previous INI CET question, which was about the glycemic control, and they asked you about the estimation of blood glucose. Of course, over there, we were using the presence of the gray colored vacuum container, which contains sodium chloride and potassium oxalate. But in this one, you are actually estimating the hemoglobin. So undoubtedly, the answer that you have to remember over here is going to be something like EDTA, right? The lavender color vacuum container that we have been using. There was another question about vacuum container, which was asked in the exam, wherein the preferred vacuum container by which you can have an estimation of the serum electrolytes in context of the patient. And of course, no difficulty in any of the people to answer that we would be preferring something like a green vacuum container. The other options, as I am going live over here with you, happen to be options like the purple vacuum container, There was another one which was mentioned as the gray vacutainer. There was another one which was perhaps mentioned as the yellow vacutainer. So the answer was what was known to already you. Heparin, color is green. Heparin, color is green. That's what we have been talking about time and again. Right? Of course, anybody who had done their internship with the degree of sincerity would be able to recall that. Then we had a question in the exam which was about, an extended maths, the kind of question which was easy. So if I am able to recall the options correctly, this was Duchenne's muscular dystrophy. We had cystic fibrosis being mentioned. We had Leber's disease given in the question. And what we were asked was the pattern of inheritance. So in context of Duchenne's, as we understand, this was again a modified repeat of the question asked earlier in the INI itself. So this was X-linked. Cystic fibrosis, of course, is autosomal recessive. We are talking about Leber's, which is going to be having the presence of mitochondrial inheritance, right? Maternal inheritance or mitochondrial inheritance. And then somebody did make a mention of a trinucleotide repeat. I'm not very sure about what was the exact option over here and what did they give you in the exam, but if you are able to recall, so trinucleotide repeat was what was mentioned, right? So if you are able to recall the disease or the pattern of inheritance, that is going to be, the obvious correct option that is going to be seen over there. Then a question was asked in the exam about a patient who was having the presence of a swelling. And this swelling was present in the forearm of the patient. Some tissue was taken from this swelling. Yeah, so tissue was taken from this swelling. Okay, so it was spinal muscular atrophy. Very good. So that's a good one that you have told. Thank you so much for that. Forearm, the swelling was there and you had taken a biopsy and it was an image-based fact which was given wherein people were able to identify, as they said, Verruque body. So they were able to identify a Verruque body. Now, as and when you are able to identify a Verruque body, right, of course, the nuclear free zones that we are having over here, you would think in terms of a condition like schwannoma. If I am able to recall the other options, they did make a mention of something like whether we are dealing with a patient who's going to be having a myelin sheath. Some myelin option was there. And then is it having some kind of an association with neurofibromatosis? But I believe that the presentation of an image which showed you presence of Verruque body would have made things easier, in making a diagnosis of something like a schwannoma, right? So that is what we are as of now going to talk about. The other thing that was asked in the exam is a question, might be repeated with you with respect to biochemistry as well. So we were asked an easy question about the pathogenesis of a patient having sickle cell anemia. And all of us know that the beta-6 position glutamic acid was replaced by valine, right? So glutamic acid goes and it is, okay, metastasis common. Is that what was an option? I would just make a mention of this. Metastasis common. Okay. Okay, nevus, nerve sheath derived tumor. Okay, nerve sheath. All right. The option was there, Verruque body. Not present, pucha tha. So, okay, we'll get back to this question. Of course, we are going to be coming up with better recall and detailed explanations of the answer as well. All except question was there. This was all except. Okay, I'll just make a mention of that. Then we had a question in the exam which was on microangiopathic hemolytic anemia. So pertaining to TTP, if you can help me recall, I have two options over here. MAHA was given as one of the options. MAHA was there as one of the options in the exam. Another one which was given in the exam was patient having the presence of thrombocytopenia. It did make a mention of the fact patient is going to be having the presence of renal failure, I believe. So to my mind, of course, all these are already present, but the question says which of the following is not present as a feature of TTP. Not present as a feature of TTP. Okay, not present pucha tha na. So MAHA is obviously going to be there. Thrombocytopenia is there. Renal failure can also be seen in the patient. And the patient could be having the presence of thrombosis was mentioned. See, microthrombi are also going to be present over here. Are these the four options? Are these the four options that were there? Thrombosis was an option. Renal failure was an option. Okay. So high risk for development of thrombosis. No, so these patients are going to be having thrombocytopenia, so increased risk of bleeding. But of course, in the pathogenesis, patients are going to be having the formation of microthrombi because of the reasons that we understand. Right. Then the next one, which was asked in the exam, was pertaining to an easy question. It was a clinical presentation of a patient suffering from carcinoma of the esophagus. And what was asked in the exam perhaps was, which of the following is a true statement about it? If I am able to recall correctly, this question made a mention of the severity of dysphagia in the patient. And as we understand, we had by chance a discussion about this in a session yesterday as well. So dysphagia obviously in the patients is going to be more for the solid food in comparison to the liquid food. Thrombosis हो गया उसका आंसर फिर तो, right? So thrombosis के chances तो नहीं होंगे, bleeding के chances ज़्यादा हो जाएंगे in context of a patient having TTP. Microthrombi is in the pathogenesis. Then we had a question which was about not an example of a germ cell tumor arising from the ovary. So from the ovarian tumors, this was what was given as a question in the exam, right? And the options given in the exam were perhaps yolk sac tumor, right? Yolk sac tumor was one of the options. Another option given in the exam was choriocarcinoma. A third one that was mentioned was dysgerminoma. And we had an example of a sex cord stromal tumor as well, right? So this was granulosa cell tumor. Granulosa cell tumor, which obviously is going to be the answer. So not an example of a germ cell tumor. That is what we need to be familiar with, right? The next question was again pertaining to hemat, which was not a product or not being produced by centrifugation. Different blood products were mentioned, and which of the following is not going to be requiring or not a product of centrifugation. So I believe the options given in the exam were platelets. Another was cryoprecipitate. Then there was RBC. Can you just confirm whether it was RBCs and then it was, packed RBCs? And then there was an option which was albumin. So of course, we understand the fact in the very first step, you are going to be separating the cells from the platelet plasma. Then you remove the platelets. Then you do removal of the cryoprecipitate. So of course, the answer over here happened to be albumin. Stored RBC. नहीं, packed RBC होगा ना? Packed RBC would have been an option. There is another question that people made a mention of pertaining to blood transfusion. I'm not sure, but some question which was pertaining to stored RBCs, and there was a graph. People also said that it was perhaps a physio question wherein they talked about the dissociation of the gases with respect to the RBCs. Right? Only RBCs was there. Okay, no worries. Okay, only RBCs. Answer would still remain unchanged. That is likely to be albumin only, right? Then we were asked a question in the exam pertaining to the issue of antibodies in a patient suffering from celiac sprue. For some strange reason, they have got a special affinity for celiac sprue in the exam these days. So every time they are either asking about the clinical presentation or the antibodies that is going to be seen in the patient. All right. So if you can just let me know what was the option in the celiac sprue. Was it a straightforward question, anti-TTG, anti-endomysial antibody, or was it a tricky question? Yeah, I know. We are just coming to that. Another question asked in the exam was pertaining to APS, autoimmune polyendocrinopathy syndrome. Yeah, Nupri, could just let me know. Okay, anti-gliadin antibodies. Was it that straightforward? Slightly, a bit skepticism in my mind. Was it just about the antibody that you see in a patient having celiac sprue? Okay. So anti-gliadin, anti-TTG. It was easy. TTG was also given as an option in the exam. Anti-endomysial was also given as an option. Not seen. Okay. So what was the fourth option then? Of course, anti-endomysial antibodies, anti-TTG antibodies, anti-gliadin antibodies, all of them are going to be seen, not seen. All except, okay, except कर देते हैं इसे. So what was the fourth option? Another antibody, but nobody was working. Some HLA number was there. Okay, some HLA number was there, but we understand it was not HLA DQ2, DQ8 as we would have expected. HLA DQ 611. Okay, 6 and 11. So of course we are aware it is DQ2, DQ8, so that becomes easy. ठीक है. Marsh classification we mentioned था. Autoimmune polyendocrinopathy syndrome. This, as we understand, See, one question that had been asked in the INI. So this is an example of a PYT. This was associated with the association with something like the AIRE gene defect, autoimmune regulatory gene defect, which controls the activity of the T cell. But I believe that most of you would recall that these patients are going to be having a high risk of suffering from fungal infections, candidiasis. Patients are going to be having other important troubles, that in this kind of a condition, you are going to be having the onset at infancy. Overall, it's an example of a condition which is going to be having a low prevalence, as it is an example of a rare condition. Some of the options, इसमें भी all except था, right? And I think one of the options that was having a high association with diabetes. So candidiasis के साथ it is having a high association, right? But I believe Dilip sir has covered that beautifully with you, that it is not having a high association with diabetes type 1. So, high association with diabetes type 1 is not something which is associated as a feature of autoimmune polyendocrinopathy syndrome. Okay. Hanji, so onset in infancy, prevalence is rare, candidiasis is definitely there, but not associated with a high association with type 1 diabetes. Right? Another one that had been asked in the exam was pertaining to something like MEN2B syndrome. What was the question pertaining to MEN2B syndrome? Was it the standard, the components of MEN2B syndrome, like pheochromocytoma, medullary thyroid cancer, and stuff like that, or was it something else? If you can just help me recall that particular component. क्या नहीं होगा, क्या नहीं होगा? This is with regards to MEN2B syndrome. अच्छा, ये भी all except था. Okay. What are the options, Dr. Anupriya? All except. क्या क्या नहीं, क्या क्या options थे? अच्छा, medullary thyroid cancer. अच्छा, option standard थे. Medullary thyroid cancer, parathyroid hyperplasia. Okay. What are the other ones? Pituitary adenoma. पिट्यूटरी भी दे दिया था, पैराथायरॉयड भी दे दिया था, और आप बोल रहे हो कि ऑल एक्सेप्ट था क्वेश्चन. पैराथायरॉयड एडिनोमा वाज गिवन एज एन ऑप्शन. अच्छा, पिट्यूटरी एडिनोमा नहीं, पैराथायरॉयड एडिनोमा था. ओके. सो ऑफ कोर्स वी आर अवेयर पैराथायरॉयड एडिनोमा तो नहीं होता ना इस कंडीशन के अंदर. एंड फीवर वाज देयर, मार्फेनॉइड हैबिटस वाज देयर. ओके. अच्छा ठीक है, तो मार्फेनॉइड हैबिटस, मेगाकोलोन और वो वाला कंपोनेंट्स आपको पता ही है. Then we had another extended match the following question. And I was able to talk about this because this was about PJ syndrome, Peutz-Jeghers syndrome. मार्फेनॉइड भी था, ठीक है. पिट्यूटरी नहीं था, पिट्यूटरी नहीं होता ना वो, तो ठीक है. यूरोमा वाज देयर. ओके. There is another question that was making a mention of Peutz-Jeghers syndrome, and it is having definitely association with the serine threonine kinase 11. So this is true. What are the other options over here? Polyps, HNPCC. Okay. And did they make a mention of something like the mismatch repair? SMAD was there. Okay. So SMAD is something, of course, that we understand would be associated with the juvenile polyp. HNPCC का साथ में क्या दिया हुआ था ऑप्शन? मिसमैच रिपेयर, APC जीन वाला दिया हुआ था. ओके. So APC gene would be associated with familial adenomatous polyposis. I think this is again going to be an easy one, no? STK11 was there, okay, covered. SMAD4 was there, covered. APC, which was given, was covered. Tuberous sclerosis. Tuberous sclerosis would have been a different question, no? FAP APC, ठीक है यार. FAP APC is okay. Juvenile polyp SMAD4 is going to be okay. Peutz-Jeghers STK11 was okay. HNPCC का पूछ रहा हूँ. Did they make a mention of DNA repair? Was this as an option? 4 disease, 4 genes. So obviously there were 4 types of polyps and related conditions, and you were able to decode it. Okay, no worries. The purpose is you should be able to talk about that in the exam comfortably. Then there was a easy extended question, which was again on the tumor markers, I believe. So we had a question on catecholamines as a marker. Then there was beta HCG, then calcitonin, and AFP. And if I'm able to recall correctly, acha, no HNPCC. Okay. Tuberous sclerosis. Tuberous sclerosis. Agreed. So we were having a condition. Like obviously for catecholamines, I think the option that was had given in the exam was a straightforward option. Pheochromocytoma. This was easy. So I'm just completing it for the sake of formality. This one is going to be choriocarcinoma. Calcitonin, of course, is going to be medullary thyroid cancer. And AFP is going to be seen in association with the patient who's going to be having a hepatic tumor. TSC हुआ या TSC हुआ यहाँ पे TSC 1 and 2. The tumor suppressor genes, tuberous sclerosis gene 1 and 2, right? So this was again an extended match polling question. And then there is a question which was asked in the exam pertaining to the cardiac tumor. That was atrial myxoma. Name syndrome pucha tha, I believe. Name syndrome, right? So patients are going to be having all except question was there. All except question was there. This question was, option was wrong in the question. B2 and D2 option mistake. Achha, some typo error was there. So they had given the tumor markers and the tumor, and they asked you which of the following is not correctly matched. Okay. So name syndrome, you are already aware of the fact, no? We are going to be having the presence of nevi. We are going to be having a patient who's going to be having the presence of a tumor that we keep on talking about, cardiac auscultation and the auscultatory sound of tumor plop, atrial myxoma. Then there is presence of mucinosis of the skin. Mucinosis of the skin. And of course, the patients are going to be having over here endocrine overactivity. Endocrine overactivity. I believe the option that they gave you in the exam was Epstein's. So Epstein's here is a problem that you associate in case of congenital cardiac defects because of lithium, no? Epstein's, है ना? So Epstein's was not the incorrect one. So all except question tha, it was again the name wala question. Right? So if I just look at the questions, I hope I haven't missed out on any. But if you just look at the questions, almost like 16 to 17 questions, out of which, except for 2, I think all were doable. So this was B-cell ALL, 2, 3, 4, and 5th, 6th, I just have to look at those options again. 7th, 8th, 9th, about carcinoma esophagus, 10, 11, 12, 13, the graph I'm not counting, 13, 14, 15, 16, 17. 17 to the best. And even if we go by the discussion that we had been having, I think a good 14 to 15 were crackable for the exam. Nonetheless, this is just an indicator of the fact that once you know about a certain thing, you will feel very confident answering those questions in the exam. And I'm sure as our discussion is going to proceed further, it is likely to give you more confidence if you have got your questions correct. Don't lose any heart if you are not able to get the questions correct, because you still have a major paper coming your way for which you have sufficient time to prepare adequately, right? So do take rest, do well for the subsequent exam. All the very best from our side. And I'll just hand it over to the next educator in our team. Thank you so much for joining in.
I'll go next. Thank you, sir. I have only 3 questions. It is very rare that radiology can be solved without images. That's how it was this time. I don't need to share any images as well. So I'm going to make this very quick. There were 3 questions. One of them, I think Dr. Amrit will also discuss, was an image-based question on Zenker's diverticulum. Very cliched question, not just a PYT, it's a direct previous year question. So I think all of you must have gotten that correct. There was another question, also surgical overlap, was with primary survey. What are the investigations which are adjuncts to primary survey? We have discussed this a lot of times. So we have chest X-ray, pelvic X-ray, and EFAST. These are the only 3 adjuncts. And whenever you have 3 in the list, always, you should know that this is a potential question. So this was waiting to be asked, and we had done this a lot of times. So CT is never primary survey, it is secondary survey, always remember that. So that was the other question. The third question was on interstitial pneumonia. So they had described, the only tricky part there was they described an elderly gentleman with sputum, right? Productive cough, and they described that the chest X-ray shows infiltrates. So once you have infiltrates, and the four options, one of them was saying it's pyogenic, one of them was saying it's mycoplasma, and I think you had to pick the wrong one, or probably the right one. So basically, it is mycoplasma. Pyogenic or any bacterial pneumonia will not be infiltrative. It will be having a lobar consolidation, right? So either ways, it has to be one of the two, because two are contradictory. So whether it was correct or wrong, you can pick accordingly. Basically, infiltrative pneumonia is mycoplasma. That is what it means. Anything else that you want to tell? Those were the only three questions which I had. I think Apur sir also discussed the X-ray question, which had multiple bony lesions. So we don't have the image. Again, like nobody could find the correct image. They said it was a very destroyed pelvic X-ray that could point to end stage of tuberculosis, where you have a lot of destruction of the femoral head. But that is what it is. Yeah. So pick the wrong one in the previous question would be pyogenic then. That would be the answer, that it's unlikely to be pyogenic pneumonia. Yeah. Train bud, I think that was a integration with path. Did you discuss that question, sir? So there was a question on train bud appearance. I think theory question. Radiology was all about theory. I mean, last NEET exam, the latest NEET exam, gave a lot of importance to radiology images, and all the students started taking radiology very seriously. But this INI has again pushed it back by 5 years at least, where they have not given any images. They've just given theory science. So anyways, this is not how it is usually. Okay, so don't take this seriously. You have to focus on images and not just the named signs. Anyhow, train bud appearance is tuberculosis, and I think the question represented something about granulomas. What will you see on the path? So that was about granulomas, right? So train bud, naam mein hai TB, right? That's how we have remembered. Superficial temporal artery, I thought Nat ke sir batayenge. So yeah, the image was a CT angio, but it was an ANAT question. So I think sir will take it up, because I was against showing images today apparently. So sir will take it up. Otherwise, I cover it when we do a detailed recall. Anything else? Eosinophilic granuloma perhaps was the same question, right? Was it the same question with TB, metastasis, everything in the options? So that's a little tricky, because all of these are DDs of multifocal lytic lesions. So we have to see exactly what kind of an image it was. Okay, so maybe that we can work on a bit more and find the answer. So overall, yeah, that is all that I have for radio. If you have any other question, you can just tell me. Yeah, the brown tumor is also the same multifocal lytic lesion, right? Those were the four options: TB, metastasis, LCH versus brown tumor. So we need to see the images, right? So that's it from my end. Thank you so much. I'll invite Amrit sir to take up surgery next.
Thank you so much, madam. Thank you so much, sir. So let us get started. Surgery had a decent share of questions this time, and not very difficult. Not like your usual, like how NEET PG was. So let's quickly browse through them. Some I saw sir also discussed, so I think I will skip those. These were the questions that I got, a good 16 questions. And there are some which were anatomy, ENT overlap, which I will not be discussing, which the respective faculty will discuss. Like there was a Passaro triangle boundary question, a Zenkel's diverticulum question. So those the respective faculty will discuss. This parts are discussed already, so not a component of meant to be is parathyroid disease. One of our popular questions, every INI CET is going to ask you this question, and there is nothing you can do to run away from it. So they gave a breast cancer, a big size tumor, big size, it was more than 5 centimeters, so it was T3. There was dimpling and invasion of pec major. Remember, this will not affect the T stage. This I have discussed umpteen number of times. Practically every END, every GT will get a question on this. So this will not affect the T stage. Matted actually notes were there, but this does not really is required. So T3 is going to be the answer. And as I know, there was only one option with T3 in it. right? There was only one option with T3 in it. So answer is going to be T3. All right. And matted lymph nodes, axillary nodes is going to be N2. एक ही option था जिसमें T3 था. So that is the answer. Right? A decently tricky question. So I have given you the source also to give you the answer. That 40-year-old patient with history of prior neck radiation. This is correct. There was history of some lymphoma for which he received neck radiation. And they had told you it's a papillary thyroid cancer. So all this was given. And they are asked, what is the treatment? Now, let's be clear, papillary thyroid cancer, MRND, had two options. So MRND is out. MRND is not going to be the answer. So you have to only choose between hemi and total. If there is any risk factor, answer is going to be total. Okay, yeah, there was, so if there is any risk factor, and this is from Sebastian, you don't need so much detail. Anything which was wrong, you are going to do total thyroidectomy. So if it is like you see over here, radiation-induced differentiated thyroid cancer, answer is going to be total. Even though only one lobe was affected, safe bet is going to be total. Okay, anything you see wrong, say total. Don't mark hemithyroidectomy. So this what source I have given you is there in Bailey and Sebastian, two places. Neck nodes were not involved. So neck dissection is you are not going to do MRND anyways. You will do central compartment, right? You will remove the Delphian node level 6. So anyways, you are not going to have any connection with neck clearance here. So answer is going to be total thyroidectomy. Yeah, because it's a radiation-induced neck cancer. Properly mentioned on right side. Still, my answer would be total, not a hemi, because they have given you some risk factor. If any of these risk factor was there in the question, the answer will become total. Like question is saying he has received neck radiation. Done to death question, many times it has been asked. Not a component of primary survey is going to be CT scan, right? These were the other options, I believe. This a lot of students said, very nice, very fancy question with a lot of detailed options. So patient had polytrauma, he was breathless, he had a low blood pressure, breath sounds were absent. The history that was given was suggestive of a tension pneumothorax, is what the students told me. They ऐसी कुछ history थी. And the GCS was below 8. This also they had mentioned. So polytrauma, head injury, chest injury, multiple injuries, and they had asked, what are you going to do next? Some options students said they could clearly rule out. One option was the only one where they said airway securing ICD placement. So that, in my opinion, is going to be the best answer, because GCS below 8, you are going to intubate. That's our dictum, right? Below 8, intubate. ICD placement for tension pneumothorax. So follow the ABCD rule. The answer is going to be airway securing. Correct. GCS less than equal to 8, you are going to intubate. That's fine. So GCS is 8 by 15. You are going to intubate. I know options are very elaborative. I am very sure that, but the history was suggestive of head injury, tension pneumothorax, correct? Wonderful. So yeah, absent breath sound. So go for this one, airway securing ICD placement, IV fluids, that is the best answer. This first third already discussed. That post-gastrectomy, lower limb numbness, this is going to be B12 deficiency. So because of loss of intrinsic factor. This also, sir, discussed earliest symptom or common symptom of C esophagus dysphagia will be more to solids. You know, I always say these kind of questions will not come in the exam because they are not clinically very relevant. But see, it came. You know, it's so funny. Why are they still putting these things? I don't know. But INI CET, as ma'am was saying, has gone 5 years back. It should not have. Means ऐसे question नहीं आने चाहिए थे. It has gone 5 years back, maybe 20 years back. Then there was a clinical question. They gave history which was suggestive of ureteric colic. And the examination was normal. And they had asked, what is the best imaging? Okay. And I asked this from 3 students. They all said, sir, they said, what is the best imaging? Imaging. Answer is going to be plain CT KUB. Okay. It's not ureteroscopy. If they ask best imaging, and they are not saying it is ureteric stone, right? Nothing in the history was suggestive of ureteric stone. It was only suggestive of ureteric colic. So the best imaging is going to be plain CT KUB. Clear on this? Okay, wonderful. So yeah, best imaging. Thank you, Anupriya. This is medicine more than surgery. Tool-Levin-Witt classification system is used in severe ulcerative colitis. right? CCT, are you sure CCT was another option? I don't think they would trick you so much. Okay, but plain CT will still be the answer. Even if CCT was there in the option, still answer is going to be plain CT. They are asked best imaging. This was the only new question that came. It's there in our main videos and all. Normally, एक तो laparoscopy oriented questions they will always put, right? So, what angle is seen between the laparoscopic working port, that means the instrument, and telescope cord or camera was called? Okay, so they asked you what is the angle between the camera and the laparoscopic instrument. So this answer is azimuth angle. Okay, I believe the other angles were also there in the options. This answer is azimuth angle. It should be at least 30 degrees, right? Okay, so this was one new question. Little bit tricky, but if you knew this, if you have done any exposure to laparoscopy, then this is the answer. Yeah, it is this angle only, the angle which is between the telescope and the laparoscopic working instruments. It should be at least 30 degrees. Okay. This is a repeat. It has come many times. It came in NEET also. They gave a history. Okay, they gave a history from patient who is suffering from pressure sore on examination. Some skin is broken. What is the grade of the score? Okay, patient who's suffering from pressure sore on examination, some broken skin is there. What is the grade of the sore? This is going to be grade 2. Okay, so grade 1 is non-blanching erythema, grade 2 is partial thickness skin loss. So this is going to be grade 2 pressure sore. This is more microbiology. You can help me on this question a little bit. ऐसे ही कुछ था that there was hepatomegaly and person was found to have a liver cyst, and they aspirated the cyst and they had given the image of the cyst, of the fluid that was aspirated. So I think it should be echinococcus. This I will put a star mark over here because the other worms don't cause liver disease. Like I believe the other worms were Taenia saginata, solium and all. So I don't think they cause liver disease. They expect you to mark hydatid cyst only. Okay, but this I will leave to microbiology ma'am to confirm. Okay, because they had shown how the fluid was on aspiration. Yeah, H. nana was the fourth option. Okay, thank you. So this was a normal microbiology question. Then this was an easy question. Which of these is seen in acute pancreatitis? So lipase is more specific than amylase, is correct. Lipase requires 30 days to return to baseline is not. Lipase does not reflect severity. We have done this many times in our class. So this was a straight away answer. Okay. This a lot of students asked me, what is the correct answer is this? During separation of spleen, was this an intraoperative question or was it a post-operative question? They said during separation from spleen from the stomach, during splenectomy, which of these vessels is likely to give bleeding? So the answer here is going to be short gastric. So what separates the stomach from the spleen are the short gastric vessels. So when I'm doing a splenectomy, these vessels are likely to bleed. Okay, so short gastric is going to be the answer. Another normal standard question, they gave findings of hypercalcemia, elevated PTH levels, mass below the thyroid. So you had an idea that this was a PTH disease. Okay, this was a parathyroid related disease, mostly a parathyroid adenoma. And they had only asked only one option had where you are going to do a parathyroid removal. So that was the answer. Other options did not have anything related to parathyroid removal. So intra bleeding also answer will be the same. It is going to be short gastric. Short gastric is where you expect it to bleed when you are dissecting the spleen from the stomach. See, neck exploration, I think both were in the same option, MIBG scan with neck exploration. I think both were together. It was one option only, if I'm not mistaken. Because students many of them told me that there was only one where parathyroid was the treatment. So answer is going to be this. I don't think this was a tough question. Most of these are there everywhere. You will find the answers. Correct? Focused parathyroidectomy or minimally invasive parathyroidectomy. The only truly tricky question, which is INI CET NEET PG standard question, the only truly tricky question was they had given a photo. This question's answer I also had to think, and that's why I put this table from Bailey. That they gave a picture of oral malignancy and they asked what is the T stage, and it was a floor of the mouth tumor, if I'm not mistaken, and they asked what is the T stage. Now, technically, if it's a floor of the mouth tumor, you should know, right? T1, T2, T3, T4 less than 2, 2 to 4 more than 4 centimeters, but they have not given you any size. So how do you know what is the T stage? Well, fortunately or unfortunately, it is all there in this table, where if you look over here, T4A, tumor invades or involves the floor of the mouth. If this was the tumor involving floor of the mouth, answer is going to be T4A. Okay, because students told me image was the floor of the mouth tumor, answer is T4A. Otherwise, it is based on size. And T4B is very clear. We have done so much of oncosurgery. It is locally advanced. That is T4B, unresectable organs, base of skull and all. That you won't get on a photo. So definitely, answer is going to be T4A. Bada size tha, going to the teeth everywhere. My answer would be T4A. Right? So good questions, not very difficult. Many PYTs, some were PYQs, also standard topics. I believe you would have gotten most of the questions comfortably unless you made silly mistakes. So I hope you had a good experience solving the surgery questions. Keep studying hard. Now I will hand over to the next faculty. Mukta is going to be next. Okay, Dr. Raina is here.
Hi, everyone. So,
Over to Dr. Raina, ma'am.
thank you, Dr. Amrit. I'll just share my screen. Yeah, so hi everybody. I think OBG was quite easy. It wasn't something again INI level at all. It was more of a NEET PG sort of exam. I didn't find any tricky question, but let's go through the questions. The first question was early onset preeclampsia is defined as, and we've discussed this in our classes, that we divide preeclampsia in two ways. We divide them either as severe and non-severe, and the other way we divide them is early onset and late onset. And early onset is defined as preeclampsia before 34 weeks. Okay, and the way to prevent early onset preeclampsia is by giving ecosprin. That's another commonly asked question. So the answer here is before 34 weeks of pregnancy. Now we go to the next question. The next question was also quite easy. This is what is restitution? And again, in mechanism of labor, we all know the steps starting from engagement, then descent, flexion, internal rotation, then the head is born by extension, then restitution. So restitution is nothing but untwisting of the twisted neck. So when internal rotation takes place by 1/8 of a circle, when the head is free from the confines of the pelvis of the bony cage, it simply untwists by 45 degree. And that movement is called as restitution. So again, simple, straightforward question. If you know a little bit of your basics also, you'll be able to answer this. Now, this question, I got a lot of queries, and when I take my classes, I don't tell incidences or percentages too much, but this is one percentage I always tell, because it usually comes, and somehow since we've been students, our professors always teach this, and I also keep teaching this to my students. I don't know why, but it is important. So very few incidences are important, and I just talk about 3-4 important percentages in my class. This is one of them. So female infertility accounts for 40%, male infertility for 30%. Okay, and the remaining 30%, this is 70. The remaining 30% is 15% is unexplained. Okay, and 15% is combined both male and female. So this is 15% is the cause of unexplained infertility. So if you see any of my lectures, be it main videos, be it mission, be it marathon, somehow I always tell this, and probably this is the reason why. Okay, which step is not included in active management of third stage of labor? So I'm not sure about the last option. Okay, but this is very, this is quite clear. I've always told you again, AMTSL, the basic AMTSL by government. I think I disappeared. I'm sorry. Just give me a second. Just give me a second. Okay, so after delivery of shoulders, even if it was mentioned, I'd still stick with bimanual compression as the better answer, because that's for management of atonic PPH. Okay, not part of prevention. Next question is something which is asked in every exam repeatedly. This itself is telling you that this is imperforate hymen. Okay, so bluish bulge. They present commonly with cyclical abdominal pain, urinary retention, bulge in the abdomen. Okay, and then you get confused between these two. But remember, a TVS, if it's especially a low TVS, will not have the bulge because it's thick. Okay, whereas a hymen is very thin. So the blood bulges out and you see the typical bluish bulge. Okay, what was the fourth option? Can anyone tell me the fourth option? So I just complete the question. Okay, let me know the fourth option. I'll check. I'm repeatedly getting stuck. Just a second. Okay. Next question. A 24-year-old presented with secondary amenorrhea with primary infertility with value of LH 0.3, FSH2, prolactin 20, TSH 1.2, BMI 17.5. So again, I've told you in the classes that they may give you the value. So you should know what is normal, what is abnormal. I have told you anything more than 10 is high for FSH and LH, and anything less than 1 is low for LH and FSH. Okay. So this is hypergonadotrophic hypogonadism. This is hypo. So here you have LH 0.3. FSH is 2. It's a little in the normal range, but it's still low, on the lower side. LH is definitely low. So this is hypogonadotrophic hypogonadism. Like you see, a common example would be Sheehan syndrome. So you have where FSH, LH also are low. She has secondary amenorrhea with primary infertility. So this is hypogonadotrophic hypogonadism. So this is Ovira syndrome. I'll just add it here. Okay. Next question. The shortest anterior-posterior diameter of the pelvic inlet. So what's the shortest anterior-posterior diameter? So, or I think this was the shortest diameter or the AP diameter. I'm not too sure. But if you have 3 AP diameters, you have the diagonal conjugate, which we actually measure. Okay, this is the sacral promontory. This is the pubic symphysis in front. Then you have the obstetric conjugate, true, or the anatomical conjugate. So the shortest conjugate is the obstetric conjugate. That is the one through which the baby actually has to pass through. Okay, so this is what is the correct answer. Again, diameters, they won't ask you the exact values, but if you understand the concept, you'll be able to answer this better. Next question. So there was a clinical scenario of an ectopic pregnancy. Choose the incorrect statement. There was something given about shock in a patient. Okay. And they were asked, what is the incorrect statement? So there was an option of oral methotrexate, which is never given. I'm not sure about the other options. Pain is definitely the most common symptom out of the triad of symptoms. Okay. But what were the other two options? If you could just let me know in the chat, in the comments, I can see and then see. Okay, so here there was a fourth was true conjugate. So true and anatomical are the same. So there are two other options, but there was one incorrect option, and we don't use oral methotrexate. I think there was a more specific answer that it is given in cases of when you can't give methotrexate intramuscular, you give oral if a patient has kidney failure, something like that was given. Okay, PID and sexual related. Okay, I thought that was a different question. So I think it was the same question then. Yeah, methotrexate in renal disease was mentioned. But anyway, we don't give oral for management of ectopic pregnancy. We always give intramuscular. Okay, then there was a question on cancers and tumor markers. Match the following. I think it's been discussed in pathology, so we won't discuss this here. This was also a very straightforward question if it was from the gynae tumor section. Then there was a question on histopathology of what I have gathered from most students is that it was shown over secretory endometrium. And it was asked the hormone responsible for this is secreted by. So secretory endometrium, if the picture was of, it is secreted by progesterone. It is caused by progesterone in the luteal phase of the cycle. And luteal phase of the cycle, that means the hormone is secreted by the corpus luteum. So corpus luteum secretes progesterone, and that creates the secretory endometrium. Okay. All right, I'll come to that question on the large cyst. Okay. Next question, which is not an indication for an instrumental vaginal delivery or specifically a forceps was asked. Again, not very sure which it was. But it's very obvious for CPT, you will not apply any instrument. CPT becomes a direct indication for a cesarean section, whereas in fetal distress, maternal exhaustion, and prolonged second stage, and the fourth indication to do a instrumental delivery is if you want to cut short the second stage, then you would do an instrumental vaginal delivery. So CPT is the correct answer. Okay, so it was forceps. All right. Okay. Okay, a patient came with vaginal discharge with odor and the whiff test was positive. We all know whiff test is for bacterial vaginosis. The question could not have got simpler than this. Okay, and I've always told you from vaginal discharge, you are definitely going to get a question both in the INI and in the NEET PG exam. Okay. Next question, when is delayed cord clamping done? So remember, delayed cord clamping is the norm. It is done in all babies, term and preterm, especially preterm, because preterm, the incidence of anemia is higher. Any baby not requiring resuscitation, you are going to do a delayed cord clamping. All the rest options were there to confuse you. This statement has been taken up directly from the WHO guidebook, so guidelines. So vigorous term and preterm babies not requiring resuscitation. Any baby, whether it requires resuscitation, you will do a immediate cord clamping. Again, AMTSL is a very, very commonly asked question. So I've told you this, PPH is a very common area where they ask questions from. Next question. Okay, so this was a bit of a confusion because students have told me that so it's a very easy question. It's a repeat question. Quadruple test के components क्या क्या है? ठीक है. Now beta HCG, alpha fetoprotein definitely. Inhibin A is a marker, so inhibin B is out, right? So it should be inhibin B. But many students are saying that it was given as estradiol, not estriol. Remember, we use unconjugated estriol as the marker, not estradiol. The component of the is estriol. So if you think about it, this is between both. I would think this is probably a typo, and I would go with this because the name of the test is actually dimeric inhibin A, and it's not inhibin B. So most likely this would be the answer they'll be looking for. But yes, I understand your confusion because estradiol is not a marker, estriol is. So again, I don't know why. I mean, I feel it's just a mistake from their end, not so that becomes a bit unfortunate for those who've marked. I don't even know what the correct answer they've thought of, but I would mark seeing the previous because this question has been repeated several times in INI itself in the last 3 years. This is the third time it's coming, and this was the answer. Okay. So next question, mitochondria of spermatozoa. This is from anatomy. I guess you could put it there, but also from gynae. And we know that the mitochondria is in the neck. in the connecting part. So this is the correct answer. So you have the spermatozoa, here you have the nucleus, here you have in the connecting part, you have the mitochondria, and then you have the remaining sperm. So the connecting part contains the mitochondria, which is not a germ cell tumor, already discussed in pathology. Granulosa cell tumor is a sex-caused stromal tumor. All the rest are examples of germ cell tumor. Again, very straightforward question. Okay, so again, not much clinical questions came, which is unusual. Yes, I know, but the questions that came are pretty straightforward. Physiological changes in pregnancy all occur except, so we do know there is fasting hypoglycemia and postprandial hyperglycemia. Remember, blood pressure falls. In the first trimester also it falls. Maximum fall is in the second trimester. It doesn't increase. There is a fall. There is increase in RBC mass, which is not in proportion to the increase in blood volume, hence the physiological anemia. And there is increased peripheral insulin resistance. So there is a decrease in the blood pressure, not an increase in the blood pressure. Okay, inhibin A was given. So if inhibin A was given here, तो फिर आंसर estradiol हो जाता है. अगर यहाँ पे estradiol था तो आंसर inhibin B हो जाएगा. So just remember the components. The components you should know are alpha fetoprotein, unconjugated estradiol, beta HCG, and inhibin A. Okay, and जहाँ पे B है, wherever you have B, these are increased and these two are decreased in a mother whose baby has Down syndrome. Okay. Next question. Dr. Savita is posted in a low resource hospital setting. So this is a low resource setting. She explains the female about risk factors of cervical cancer. I think this was of cervical cancer, including HPV. Right, I think this was what was given, which should be appropriate for cervical cancer screening. Now, remember, we know the best test, of course, is the HPV. Okay, but remember, this is a low resource setting. So the WHO and the American Cancer Society guidelines clearly say HPV is the best test, but they also say that if not possible, then the preferred test is pap smear alone every 3 years, because this is a place and low resources specifically mentioned for this reason. I've told in my classes also, the HPV is a very expensive test. It's yet not freely available for all, and many patients will not be able to afford it. So pap smear is the best test if you're doing a pap smear once every 3 years. Okay, a case of, so these other two options were there in that ectopic wala question. So I'm skipping this. I got 2 options there and 2 options here. So I thought it was 2 separate questions. Okay, and this was the last question. Again, this was the only confusing question I found, which might have been confusing, but I need a bit more detail in this. What else was asked? A 24-year-old woman with abdominal pain with a 14-week mass. So a large abdominal mass corresponding to a 14-week size uterus. On ultrasound, there is a 8 by 5 centimeter ovarian mass. She's a known case of rheumatic heart disease on warfarin. I think some other risk factors also, I mean, other medical conditions were also mentioned. Okay, what is the next best step? Okay, so here she's come with pain. Remember, I've told you this, any cyst or any ovarian mass more than 8 centimeter, and even if not symptomatic, she is symptomatic, she's having pain, you do surgical exploration. Whether you do laparoscopy or laparotomy is a different question, but you will operate on her. You will not leave her alone. It's a huge mass corresponding to a 14-week size mass. Yes, CA-125 is also a good option. I know that. Okay, but it's unlikely in a young girl that you would find a cyst adenocarcinoma, okay, where it is raised. But yes, this is also, I could understand the confusion here, but anything, even if the CA-125 comes low, it's not that you won't operate, it won't change your management. That's why surgical exploration is the best answer. Okay, and what surgical exploration to do probably would depend on your CA-125 levels. But still, the better option here would be a surgical exploration, probably laparoscopy or laparotomy, and then do a cystectomy or a ovariectomy, or maybe more depending on other risks. Okay. So uniloculated cyst was given. Okay, still it will not change. Of course, if multiloculated, definitely do surgery. Uniloculated would be more. So even if you see the table in Novaks, which I teach from, the table in Novaks clearly says less than 6, don't operate. 6 to 8 is the doubtful time when you don't know what to do. Then you do C125, but more than 8, you definitely have to explore and see what is there. Okay. Next step is you're going to plan her for surgery. Okay, even if the CA125 comes normal, you will still plan her for surgery. So that's what I'm trying to imply. Surgical exploration is the best. So that's what I got from Obs and Gynae. If there are any other questions, let me know. Okay, and we can discuss this question further because I still need to get more input on this question. I know it's a little controversial. So over to you, Doctor. I think Dr. Anand is here.
Yes, ma'am. Good
Thank
evening, ma'am. Yeah, hi. How are you? All good? So
Yeah,
many
yeah.
questions.
Yeah, a lot of questions from Obs and Gynae. Always comes. Always.
आपके कहाँ पढ़ा रहे हो इतने सारे question? That's nice. Very nice.
Right.
Thanks.
Okay.
Yeah. Good evening and regards. My name is Dr. Anand. So I'm just discussing like this only questions, and we had questions in milestones, Guillain-Barré syndrome, celiac disease, cystic fibrosis, rotavirus, and overlapping topics of ALL and PNH. The first question we have over here is like I'll be asking you quickly questions. Number one question was the most common organism causing croup. The most common organism causing croup, the options were Streptococcus pneumoniae, influenza virus, Haemophilus influenza, and Staph aureus. So we all know that the most commonest cause of croup is para-influenza virus. Para-influenza virus. Second question was 2-year-old baby with the watery diarrhea and severe dehydration. Watery diarrhea and severe dehydration. What could be the likely cause? Watery diarrhea and severe dehydration. The options were Staph aureus, rotavirus, E. coli, Shigella. So the most commonest cause of virus in pediatric population is rotavirus actually. So rotavirus was the answer. The question was a child was able to make a cross. A child was able to make a cross. So a baby can make he was able to make a cross, tell stories, and able to make a tower of 6 cubes. So baby can make a tower of 6 cubes by 2 years, and a child can make a cross. He can make a cross by 4 years. So the options were 4 years, 2 years, 5 years. Baby can make a cross by 4 years. He can tell poem and stories by 4 years. So that was the question. A baby can make a cross, tell stories. So it means the baby is 4 years. 4 years was the answer. All are the live vaccines. All are the live vaccines except the options were hepatitis B virus, measles, rotavirus, varicella. So we have the mnemonic smallpox, chickenpox, MMR, BCG. Smallpox, chickenpox, MMR, BCG. They all are live vaccines. Smallpox, chickenpox, MMR, BCG, and OPV are live vaccines, and rest HPV, hepatitis B, it will be a killed vaccine. So then the question was regarding the breast milk jaundice. One of my topper students, Sarthak, told that breast milk jaundice pitha. So breast milk jaundice is because of increased breastfeeding. It is seen in the second week of life of a baby, and the more the mother will breastfeed her baby, the baby will have jaundice. And the question was regarding the neonatal jaundice also, and regarding the biliary atresia. Which of the following statements are false? So the most common cause of neonatal jaundice is biliary atresia. This statement is false actually. The most common cause of neonatal jaundice is biliary atresia. This statement is false. So it's false. So the question was from breast milk jaundice, neonatal cholestasis, vaccines, milestones, and rotavirus, parainfluenza virus. That's it. Over to ma'am. And of course, we're going to make a proper video and post it on the Cerebellum channel. Good evening, ma'am. I hope your health is okay. Thank you.
Thank you, Dr. Anand, for a wonderful recall of pediatrics. And from here, I'll take it for recall of anesthesia. So we've had 6 questions in anesthesia. The first question was this IV anesthetic agent that causes adrenocortical suppression. So this was a very easy one. We know that steroid suppression is caused by nothing but etomidate, and that is the answer for this. Now, this question, I had a lot of students who were confused about this. A person has suffered from chest trauma resulting in fracture of 2nd to 6th rib. So multiple rib fracture was given, and they had said that he was given IV pain relief drugs, but that was not enough. So which of these blocks will be helpful in pain relief? So this was a slightly tough question, but it just required some common sense and ruling out of the options to get the correct answer. So first, let me tell you what's the correct answer. It is the thoracic epidural. All right. Now, why not the other options? So cervical plexus. So if you're going to give a cervical plexus block, it is only going to cause numbness of the neck and the upper shoulder. Okay. So that is where the cervical plexus supplies sensations to. So this cannot be the answer. Second, supraclavicular block. Supraclavicular block is nothing but an approach to the brachial plexus. As we had studied, we have interscalene approach, supraclavicular approach, and axillary approach. All 3 are approaches to the brachial plexus. We know that the brachial plexus supplies the arm. Okay. So any kind of fracture of any bones of the arm, you will give a supraclavicular block. But the ribs are not going to be covered by supraclavicular block. Then the two options were thoracic and lumbar epidural. So lumbar, if you're going to block the lumbar nerves, obviously it is not really going to help in the rib fracture. But thoracic epidural, when you place it and you give pain relief drugs, that is, you give local anesthetics through the thoracic epidural, definitely it will help, especially in multi-rib fracture. Okay, so you're having 3rd to 8th or 2nd to 6th ribs, whatever fracture. So it will help in spreading the local anesthetic to all of those ribs. So that is the answer. Next one, again, this was something which you could have got by elimination as well as thiopenton comes in pharmac as well as in anesthesia. So which of these statements is incorrect about thiopenton? It is highly lipid soluble. That's absolutely right. Both Goga sir and me have taught you this. Second, it achieves maximum concentration in the brain after IV infusion. That is also correct. That is why we use it as a hypnotic, sedative, anesthetic agent, because after giving the drug, within 1 minute of injection of the drug, almost 60% of the drug quickly goes to the brain. And through the brain, it will cross the blood-brain barrier. We know that the blood-brain barrier is also made up of lipids, and thiopenton, being highly lipid soluble, will cross over the blood-brain barrier and reach into the brain and act. Okay. Next is redistribution happens to adipose tissue and muscle. That is absolutely correct. I have discussed this with you all multiple times, that the action of thiopenton is short acting, because initially a lot of it reaches the brain and then all of it gets redistributed to the fat and to the muscle. Okay. The rapid decline in its effect is due to renal excretion. Now that is false. The rapid decline in the effect of thiopenton is because of this property of redistribution. Goes to the brain, causes sedation, then it gets redistributed to the rest of the body, so patient can wake up, he can become conscious. Okay. Eventually the drug does get excreted by the kidney, but that is not the reason for the rapid decline of the action of thiopenton. All right. So answer over here would be option D. Jackson-Reeve circuit, super duper easy. JR circuit, we know it is Mapleson F circuit. It is used for pediatric controlled as well as spontaneous ventilation. So your options were pediatric, adult, obstetric, and cardiac ventilation. So it's used for pediatric ventilation. Now this one, which of these is the correct statement regarding CPR in children? Again, covered both in peds and in anesthesia. So chest compression to ventilation ratio in children, when there are two rescuers, should be 30:2. So that is false. We have discussed that in children, the need for oxygenation is more. So if I have two people who are performing CPR, the chest compression to ventilation ratio should be 15:2. Okay. Depth of chest compression is 1/3 of the AP diameter. So this is absolutely correct. Next is adenosine is given via intraosseous route. So generally, if you see in CPR, we don't give adenosine. In cardiac arrest, adenosine is not involved in any of the drugs. Adenosine is a treatment for supraventricular tachycardia. And if it has to be given, it is preferred to be given IV because it has a very short duration of action. Okay, so this is on option is wrong. And the last one is adrenaline is given in the dose of 0.01 mg per kg, IV or IO, that is intraosseous, in 1:1000 concentration. So everything about this was correct till we come to this concentration. So in children, whenever we give adrenaline, IV or IO, the dose, the concentration is 1:10,000. Okay, so this is also wrong. So the correct answer is option B. Okay. Then this is something which I found tough, to be very honest. Ambu Aura 40 is what generation LMA? This Ambu Aura 40 is a reusable Ambu LMA, which has recently come out. It is not even available in many parts in India. It has a predefined shape, and they had asked which generation does it belong to. So going through many articles and going through many like marketing sites for this Ambu, we nowhere is written what generation of LMA does Ambu Aura 40 belong to. But considering the features of all the Ambu LMAs, all Ambu LMAs actually belong to the second generation. What are the features of it? That it has better seal pressure. It has a gastric tube on the side for allowing gastric emptying. Okay. So this, my best answer would be second. Third and fourth is a misnomer. So there are no third and fourth generation LMA. And the first generation LMAs have all the Purana wala, LMA Classic, Unique, all of those. Okay. So my best answer for this would be second generation LMA. All right. And I did not get this question completely. So I will discuss this in the main videos. Which of these is not advocated in ERAS protocol? The only one option that I got is that there should not be prolonged fasting in ERAS protocol, but I did not get the other options regarding this. But when I get this complete question, I will discuss it in the main recall video. So I think the rest of it were pretty easy and approachable. And I hope that you guys did well in the exam. Over to Pooja ma'am for physiology recall.
Thank you, ma'am. Thank you so much. So hello, everyone. I hope it's visible and I'm visible and audible to you guys. So let's start with the physiology recall, right? So there were so many questions of physiology, and I'm happy that we have discussed the concepts and very nicely, right? So first question was this, that the match the following hormone to the receptor. Right, to the receptor. So first question was this, and it was pretty easy. We have discussed that the thyroid hormone will be having nuclear receptor. Acetylcholine is going to be acting as a ligand-gated channel, which we have seen in the excitation contraction coupling, right? And growth hormone, I told you, piglet, right? Dirty piglet, which is going to act via cytokine receptor. But over here, they have given the pathway, right? And that is going to be a JAK-STAT pathway. Insulin, everybody knows insulin and the growth factor, they were tyrosine kinase. I hope everybody marks this correctly. All right. So I have matched this. I don't know how it might be, up and down. The column options can be up and down. I hope you were able to solve this. Let's move on to the next question. Which of the following is not seen in the inner segment of the photoreceptor? Now, when we discuss the special senses in the CNS, in that I have shown a picture of it, and you have to remember that the discs are outside. I always tell you in the classes, the main classes, that the discs are outside, right? So discs are not there, discs are outside. Even if you have a visual, this thing, what thing? The visual of this diagram that I've shown you in the classes, so it is going to be the discs, right? I hope you got that correct. So this is the diagram of it. Everything is going to lie in the inner segment mainly, and the discs are going to be outside. All right. So that is the second question. The third question was pretty easy if you have attended the full classes. Now the trick over here was the static. Static 2-point discrimination. I told you the best is going to be the Merkel's disc. And remember, some of the students told me that, ma'am, it was the Ruffini endings which were there. Some told, no, ma'am, Ruffini was not there. Instead of that, all of the following were, or all of the above were there, right? Now understand, when they have mentioned static, static is mainly for, this is mainly for, I'll show you the this thing also. This is static and dynamic. We usually do that in the PG level. We don't expect that to in the UG level to solve this question. But still, over here you can see that it is static is for slowly adapting. In the PG classes, I usually tell them that S for S. Remember that static is for slowly adapting, and we know Passy has messy hair. That is going to be rapidly adapting. For that, we are going to have the different procedure, right? We move the whatever instrument we have, discriminator we have, right? So it is not going to be all of the following. All of the following will not be the option, since they have particularly mentioned static. If the static word was not there, somebody told me that, ma'am, Braille reading was asked. Either they ask about the Braille, right, or they ask about the static. It is going to be Merkel's disc. For me, it is the Merkel's is the best one, right? So Measles nahi tha, to pakka hi Merkel hoga. All right. So okay, Gaurav, thank you. So all of the following will not be the option. Option will be Merkel. All right. Let's move on to the next one. The next one is, which one of the following curve shows the oxygen hemoglobin dissociation curve when the stored blood was transfused? I told you, you have to put a right tag on this question, right? Every class, I told you that you have to put a right tag on this question. And I discussed specifically about the stored blood and the fetal hemoglobin. Jisne wrong kiya hai, the bridge is ready, right? Pack your things, right? I'll leave you on that bridges. I told you, you have to put a right mark. And I told you that in the main classes, we have discussed that hemoglobin has the property of cooperative binding. And that's why it is going to show the, you can say, the sigmoid shape, right? The shape will not change, right? So linear, this thing is not at all possible. A and D is not possible. C is the right shift and B is the left shift. The answer over here is going to be option B and B only. Left shift. There is no doubt in this. Okay. So stored blood, two reasons I have given this, that 2,3 ppg is lesser in the stored blood, plus the temperature is also lesser. And I told you have to put a right tag. I hope all of my bacha party has marked this correctly because we have discussed this, right? I cannot afford this. We cannot afford the wrong things in the discussed questions. Now, this was very funny that student told me, ma'am, there was a diagram, but they were given just randomly the arrows, right? This A, B, C, D was not there, and they have just given the random arrows and they have given the option. So don't worry about that. That will be counted as a bonus marks. Don't worry about it. Okay. Still, I have to mark one thing. Then I'll be marking Zaham. We have discussed from the periphery to the center, right? It is going to be Zaham. We have discussed this, okay, in the classes. So what we can do is, see, Anupriya, I don't know what teachers have been telling you. I told you whatever physiological reason behind it, right? And whatever answer we should be giving, okay? It is clear, it is pretty clear. Stored blood jab bhi aata hai, it is lesser temperature. And I have shown you that in the diagram also, which is of boron, all right? So if I have to mark in this question, then I'll be marking either from M to Z or Z to M, right? Because ABCD will be given sequentially, most probably, okay? So this is anyhow the bonus question. So I'll be going like ZAMH. So MH to nahi hai. So Zaham will be the good one. So option A, if I would have to mark, then I would have marked in the sequence, all right? So I marks yours only. So Anupriya, you'll be getting marked. Don't worry about it. Okay. So we are on the right track. Don't worry about it. What will you infer from the given diagram? Again, this diagram is given in the Byrne-Levy, and this is diagram which is taken from the article, right? So actually coding is something what we discussed in the PG level, and we expect these things in the INI CET, right? But what you know that when you prick something by, sharp pricking object, of course, you're going to have a pain, right? And you pinch it, right? You must have done it in the practical per se. When you squeeze something up, of course, you're going to have pain. So these are the nociceptor stimulation. Even if you don't know anything about it, can you see any response over here? No. So that means it is going to be option A. Blunt object will stimulate mechanoreceptor, but it will not stimulate the pain receptors. Okay. So option over here is option A. All right. So next, tell me about option D. Can anybody remember the option D of this? Because I didn't get any option D from you guys. Okay. So, all right. SST, don't worry about it. It's a bonus mark. Anyhow, that was a weird thing that they have done, right? So that is there. Okay. So if you remember, please let me know. So, okay, I-band was also there. Anyways, chalo. So let me know whatever changes are there. I'll just note it down. I'll take the screenshot of it. All right, let's move on. Decompression sickness syndrome, Kaysen's disease, or deep sea divers disease, right? So what is this? See over here, we have discussed bends, strokes, and chokes. What is bends? When the nitrogen bubbles, when the rapid ascent is there from the deep sea, what is going to happen? Nitrogen bubbles are going to form and they are going to get accumulated at the different places, right? Like capillaries. If it is the brain capillary, it is going to have a stroke, right? It gets accumulated in the pulmonary capillary, then the person is going to have the choke-like feeling, right? And if it is going to accumulate in the different capillaries, different symptoms will be there. Chokes, strokes, and the bends, right? Bends is what? Bone mein, synovial fluid mein, if it is accumulated, then the bubbles is going to cause the pain during the movement. Remember, when it is accumulated into the capillary, the bubbles is going to lead the capillary leak syndrome. What will happen? There will be extravasation of the plasma, and that will lead to only plasma is going out of the capillary. So it is going to lead to hemoconcentration and not the hemodilution. Okay. So hearing loss can be possible. I don't know whether the coagulopathy is there, was there or not, because some of them were told me thrombosis was there, not the coagulopathy. Doesn't matter. Hemoconcentration ke wajah se hi this is going to occur. All right. So visual disturbances, hearing loss may occur if you go more than 3 atmospheric pressure. All right. But please remember, hemodilution will never ever occur because of the extravasation. There will be hemoconcentration. All right. Pain is carried by C fiber. Okay, that was the option. यहाँ पर क्या? Right, I'll note that. Pain is carried by C fiber. Okay, all right. So, okay, that can be true. That can be true. All right. So deep squeezing causes deep visceral pain because that activate the muscle, right? They cause the deep pain. The squeeze, when you squeeze the muscle, what happens is the muscle is going to get damaged and that is going to cause the pain, which can be going by C fiber. All right. Thank you very much. Only 4. All right. So let's move on to the next one. All of the following decreases GFR except, okay. Some of the student told me, no ma'am, it was just decrease in the GFR. Then the options will change, okay. And if it is not except, then the options should have been changed. Increase, decrease. I don't know what was the increase and decrease. As per your recall, I have added over here, right. So decrease in the glomerular coefficient. We have discussed this. How do we calculate the GFR, coefficient of filtration, into NFP, that is net filtration pressure, right? When you increase the KF, of course, the GFR will increase, and when you decrease over here, the decrease KF is there now. So of course, there will be decrease in the GFR. When you decrease the glomerular oncotic pressure, the holding on pressure is decreased. So increase the holding on pressure. Protein is increased now. So holding on pressure is increased. What is going to happen? The filtration will be decreased. So of course, what is going to happen? The GFR is also going to decrease over here. This should be KF. All right, reduce glomerular hydrostatic pressure. Hydrostatic pressure, I told you, it's a pushing pressure. You are reducing the pushing pressure. Of course, the GFR is going to decrease, right? And that is going to occur. GFR is going to decrease and increase glomerular oncotic pressure. The nephrotic syndrome like diseases, of course, it is going to hold on to the water or attract more water into the Bowman's capsule, and this is going to occur. All right. So was it correct? Okay. So let me know whatever changes were there. Okay. Inshallah. Let's move on to the next question. Deep pressure with the blunt object. No activation of nociceptor. Okay. Inshallah. I'll look over here. You know. So let me know whatever changes you want me to do. I'm taking the screenshot. Meanwhile, I'll be changing that. All right. So just give me a minute. Okay. Next question was, which one of the following transporter mechanism does not require the ATP? All right. So A, B, C, D. I told you when something is going from the periphery, what is going to happen? There will be paracellular. This is what paracellular. These options, somebody told me, ma'am, the options were written. Somebody told me, no, ma'am, just A, B, C, D was given. If that is not given, don't worry about it. See over here, there is no carrier protein. It is going from the high concentration to low concentration. So it is going to be simple diffusion, isn't it? So option A is going to be simple diffusion. Option B, the channel is given, right? How I know? It is going from the high concentration to low concentration. Again, the carrier mediated is there. So most probably this is going to be facilitated one. This is going to be facilitated one. See over here, from low concentration, I'm going towards the high concentration, and that is going to require the ATP. That is going to require the ATP. So option C and D was like this. E, though it's not there, right? So let's say this was option C and this was option D. I have interchanged that. So see, paracellular transport also doesn't require anything because it is also along with the gradient. Okay, so B only and C only. The E was not in the option. So it is going to be A, B, and C. That is paracellular, facilitated, and this will not require any ATP. Next, which one of the following contributes to latent period in the single muscle twitch? Okay, let's see that. Excitation, contraction, coupling. It contains so many, this thing. All right, thank you, PG. I will definitely go over there, right? So let's move on. Okay, so excitation, contraction, coupling contains so many steps. So definitely it will take, every step is going to take some time. So that is going to contain, what is latent period? Latent period is you gave the stimulus. After some time, you're going to see the contraction. So from the stimulus till the beginning of the contraction, whatever period, you didn't see the response onto your graph, that is known as latent period. All right. So definitely excitation, contraction, coupling is going to have the latent period. Opening of sodium channel at NMJ, that will take some time. Why? Because the acetylcholine is going to sit onto the receptor, nicotinic receptor, and those receptor, they themselves are going to act like a ligand gated sodium channel. So of course, the binding will take some time, the opening will take some time. So that is also there. Transmission of impulses from the site of stimulus to NMJ, of course, that is also going to take some time. All right. So all these things. Now see over here, pumping calcium back into the sarcoplasmic reticulum. We have discussed this. Remember, sarcoplasmic reticulum, you are sending the calcium back means already you have started doing the relaxation. And what I told you about latent period, it is the time from where you have given the stimulus and you started seeing the response. That means started seeing the contraction, right? So relaxation or even the contraction will not be included in this. So please remember, it is going to be A, B, and C. A, B, and C. I hope this was clear. All right. So I hope this was clear. A was paracellular, B was diffusion. All right. Thank you, Swati. Thank you, OG. Thank you only. But I hope you understood the concept, right? I have taken the screenshot. I'll change the order. All right. Let's move on. Help me out with the, you can say, help me out, kindly help me out over here in the options. So what are the options over here? The patient had gastrectomy with neural involvement, Romberg positive, numbness, decrease in the sensation, lower limb numbness. So vitamin B12 deficiency, that was the, you can say, question I got, right? Please let me know if any changes are there or you remember any other options, okay? Kindly give me the input of the options, okay? A, B, C, D was in the option. Still, sarcoplasmic reticulum back into the calcium, back into the sarcoplasmic reticulum will not never come into the latent period. That is in the relaxation period, not into the latent period. Okay, so options they were telling me is B6 and folic acid. All right. What else? Thiamine. Fine. So these are not related to gastrectomy. So patient had the history of gastrectomy, though folic acid also has the neural involvement. But since gastrectomy was given, so I'll be going towards the vitamin B12 deficiency. All right. Okay, I need help of you guys to, give the options of these question on this question also. Physiological dead space is lesser than anatomical dead space. It is never going to occur. In the normal person, either it is going to be equal to anatomical dead space, or in the pathological condition, it is going to be more than anatomical dead space. So lesser than anatomical dead space is not at all possible. It is calculated by spirometry. Can we calculate it? No, we don't know how much air has gone into the anatomical dead space, how much air is gone into the alveolar area, right? So we do not know. Increase perfusion. Okay, physiological dead space will not increase perfusion. Okay, decrease perfusion. Just decrease ventilation. Okay, decrease ventilation might increase the physiological dead space. Might increase the physiological dead space. Okay. Inadequate perfusion. Inadequate perfusion, see, physiological dead space can be increased by inadequate perfusion. First of all, tell me, you had only one to choose, or they have given like only A, only B, aisa tha kya? Option mein only A, only B, like that it was there, or just you have to choose one option amongst these? Hanji. Okay, so give me the input on this. I'll be working on this. Okay. First of all, tell me whether it was multiple choice. That means you can choose the multiple things or the single thing. Okay, we'll work on this. Then the peripheral chemoreceptor is sensitive to. Vaguely, somebody told me that this question was there and hypoxia was the option because we do have our oxygen sensitive potassium channel. Was the channel were asked or what thing was asked? Let me know. Okay, single choice. Okay, so we have to work on it. Okay, there were so many different options I'm getting. All right. So was this option there or was this question there? Let me know in the comments, right? So decrease perfusion, only one option. All right. Thank you, poster. I'll be adding that to it. Okay. Increase ventilation will never cause increase in the, you can say decrease ventilation will never cause the increase in the physiological dead space. Rather, it will decrease it. Okay. hypercapnia, alkalosis, acidosis, other options. Okay, all right, all right. Thank you, Ankita. So we'll work on it. Okay, chalo. So the question was there. All right. So thank you so much. I'll be handing over to the other faculty, I guess. Who is next? Mukta ma'am. Praneet sir, you are the next.
Praneet sir.
Good evening, sir. Please take over.
Yeah, thank you, madam. Yeah, good evening, dear students. So ENT was very easy. All single liners were there, right? So just let me share my screen. Yeah, is that visible? Fine. So very easy questions and very straightforward questions. And let us recall one by one. Yes, which of the following is more severe? I mean, in terms of hearing loss, which of the following is more severe? Ossicular discontinuity with intact tympanic membrane. As you know, this is your canal and this is your eardrum, right? And this is your middle ear. And your malleus is broken, and in case there is a ossicular discontinuity here, the sound waves will end here. There is no continuity. The sound waves are not getting transferred on towards the cochlear side. Whereas in this case, what is happening here, perforation is there, isn't it? So through the perforation, the sound waves are entering and striking on the medial wall of the middle ear. So somehow some sound waves are entering into the inner ear, but here that is also not there. So compared to B, A is the one which is having more amount of hearing loss, right? Clear? And Carhart's notch is seen in very straightforward, very easy question. So it is otosclerosis. Carhart's notch is nothing but a dip at 2 kilohertz area on bone conduction curve, right? Okay. Right. Yeah, the stapes fixed was there. That's coming. We are coming to that question also. Stapes is another question, I think. So Carhart's notch is there, no? Carhart's notch is seen in otosclerosis, straightforward question, right? Now, identify the pure tone audiogram. So I have told you in your regular classes, if you are getting two waves in the normal, two lines in the normal area, that is normal, and both are with a gap lying in the upper part, that is conductive hearing loss. Both are near to each other in the lower area or middle area, SNHL. Both are in the abnormal area separated by a gap. This is mixed. Now you see the bone conduction curve is of 40 decibels loss. Air conduction curve is of 60 decibels. Both are more than 20, right? So both are abnormal and are separated by a gap. So this becomes the mixed audiogram, right? Okay, very easy. Straightforward question, right? Now, which is dangerous? Unilateral RLN palsy, bilateral RLN palsy. If you take unilateral, only one vocal cord will be in the paramedian. The other vocal cord will be moving. So while breathing, the other vocal cord will abduct and the patient can breathe. So compared to unilateral, bilateral is always severe, dangerous. So out of unilateral and bilateral, if you take, if both bilateral are paralyzed and complete paralysis is there. Now what happens? Your RLN is supplying the only abductor of the larynx, that is your posterior cricoarachnoid, and while breathing, your vocal cord should abduct. Then only the airway opens. If bilateral RLN palsy complete is there, the vocal cords will not abduct. Patient will land in sudden gasping respiratory distress. Emergency tracheostomy is required here, isn't it? So the option will be bilateral RLN palsy, complete palsy will be the option, right? And identify the fracture. If the blow is from the below, the line will pass vertically. This is your Chevalet fracture, right? And if the blow is from the front, that is Jarjave fracture, that will come like this, right? And if the blow is from one side, C-shaped, the dorsum will deviate like a C-shaped, right? You know that. First investigation in newborn for audiological assessment is always otoacoustic emissions. Some are saying that the clap and the smile option was there, but no, this is not the answer. Otoacoustic emissions. Even the next minute the baby born, next minute you can do is otoacoustic emissions test. And this is the commonest, most common, best investigation. Objective investigation. Clap and smile is subjective. You cannot do it properly. Objective otoacoustic emissions are the best method to rule out any presence of congenital hearing. So first investigation is always otoacoustic emissions. And if it is abnormal, then after 3 months or 6 months after, you will go for BERA next, right? Okay. Now, 4K drop was there. If 4K drop was there, If in an audiogram, if a PTA is showing at a 4K dip, 4 kilohertz dip, then it should be noise induced hearing loss. Okay, for your information sake. Okay, fine. What is the procedure done? See, this is a stapes piston that has been shown to you. This is a stapes piston was given in one of your questions. Stapes piston is inserted, is done in during stapedectomy. To the incus long process, you will crimp this stapes hook. Okay, this head will be crimped onto the incus long process, and the base will enter through the foot plate into the inner ear side. Right? Okay. You are following? And which opening is of the same level as inferior turbinate. So if you take your nasal cavity, this is your nose, right? And you have here, and this is your uvula, oral cavity, right? So here is your inferior turbinate. If you take this inferior turbinate, just 1 centimeter posteriorly, you are having opening of the eustachian tube. Behind the middle turbinate, you are having the opening of sphenopalatine foramen. Okay. Okay, if it is stepidotomy in the previous question, if it is stepidotomy also, even if stepidotomy, stapedectomy, in both procedures, you will use the piston anyhow. The difference is that in stapedectomy, entire footplate is removed. In stepidotomy, you are creating a fenestration in the footplate area, right? Okay, so at the same level as inferior turbinate, you have the opening of eustachian tube. Any more questions were there from ENT? Any more questions? All are very straightforward, very easy questions, right? If any more, kindly DM me, we'll add it up and we'll post it in the app. Any more? Okay, anyhow, you can correlate this diagram, no? This diagram you can correlate, no? This diagram you can correlate, okay? So this is your inferior turbinate, this is your middle turbinate. Posterior to middle turbinate, you have sphenopalatine foramen. Posterior to inferior turbinate, you have eustachian tube opening. Right? So much, so easy questions have been come. So much scoring could have been, might have got in the ENT. So with this, I'm ending my session and I'll be transferring it to the next available faculty. So, Muktaji, I have ended. ENT is closed. You can shift it to next one. Yes, Dr. Harshit. Yes, stapes suprastructure will be removed during stapedectomy or stepidotomy or stapedectomy. The crurae, the two crurae of the stapes will be removed. Definitely they will be removed, right? Any doubts? Can post it here. Conditioned audiometry screening test. No, you will do autoacoustic emissions only in a newborn. That is for sure. For screening of hearing in newborn, the first test you are going to use is screening, that is autoacoustic emissions only. No doubt about that. Ossiculoplasty, see the ossicular, the piston, the materials used are completely different. The question, in the question, the diagram given is that of stapes piston only, definitely. Okay. Ossiculoplasty is a part of the CSOM surgery, right? Where your ossicles, not just stapes footplate fixation. Stapes piston is fixed in stapes footplate fixation. That is otosclerosis. Okay. Yeah. See, the Dr. Ayush, yeah, you were asking that. Carhart's notch question, no? 4 kilohertz dip you were asking. Okay, 4 kilohertz is also Boyler's notch. In case of this 4 kilohertz, you will get both air conduction and bone conduction like this. Okay, at 4 kilohertz area, this is noise induced hearing loss, bone conduction and air conduction. But in case of Carhart's notch, you will have this 2 kilohertz area dip on bone conduction curve and air conduction curve. So there will be gap in between. This indicates conductive hearing loss. There is no gap here. This indicates sensory neural hearing loss. This you see in case of otosclerosis. This you see in case of noise-induced hearing loss. Right? So I think Dilip sir has come to the live. Okay, I will be transferring to sir. Dilip sir.
Hi, sir.
Yeah, I have completed, sir. You can take it over.
Okay. Hi, guys. Welcome. How you guys have done medicine? I felt medicine was quite simple and easy. I don't think it's tough. Are you guys able to see and hear me? Hi, yeah. If you're able to see and hear me, you can just give a thumbs up button or probably you can just let me know. Yeah, cool. So no worries. So I've collected some questions, maybe around like 20, 21. I'm not sure. Like these are the questions that students told me because it's a very short time. So anyway, we'll be discussing the entire recall session in a while, maybe in the next 1 week. So first, I think there was a question on true love and Witt's criteria, if you remember. So for ulcerative colitis, this is something that we're discussing in the QR as well as in the main videos. Remember, true love and Witt's criteria, I think, was this a question? Or is there anything else apart from the true love and the Witt's criteria? Okay, there was a question on PARP inhibitor in breast cancer. Wow. Okay, that's great. Yeah, so fine. So this was the question. And can you tell me what the exact question was when it comes to true love and Witt's criteria? I mean, were they asking about the criteria or were they asking something else? Okay, so this was the question. Cool. So it's a direct question. Okay, so then I think there was a question on GFR 3B as well, the stage 3B, so which is somewhere around 30 to 44 ml per minute per 1.73 meter square body surface area. And what is the question on stroke, by the way? So I'm not very sure about that because I tried getting the question. But there was a question on stroke. Okay, all right. So I'm asking about the question on stroke. So that's done. The true relevant Witt's criteria is done. So that's an easy one. Criteria for management, I'm not sure. So I'm talking about the question on stroke, guys. Okay, regarding lowering of blood pressure. So if the patient was within the thrombolytic window, then the target BP would have been less than 190/110. Or if the patient was out of the thrombolytic window, then it will be less than 220/110. So you should have seen the time of presentation, whether it's within 4.5 hours or after 4.5 hours. No stroke. Okay, then it's just an hypertensive emergency. Means what emergency? So what was the problem? That guy. It's an ischemic stroke. VP was 220/100. It was something like that. Okay. Okay, there was a question on most common inherited mutation. All right. Okay, that's a factor V laden mutation. Cool. That was something that we tend to discuss very routinely, right? So most common inherited thrombophilia. It is factor V laden mutation. If this question was asked, that's the answer. Okay, JAK inhibitor in RA. Wow, that's a good question. Tofacitinib, upadacitinib, and baricitinib, right? JAK inhibitor used in RA. Good question, man. And rheumatoid arthritis. Okay, so it must be one of the tofacitinib, upadacitinib, or baricitinib. Great. All right. So I think apart from these questions, I think there was a question on Beshe, if I'm not wrong. So they have given one option with regards to ulcer seen on the dorsum of the penis, but it's not on the dorsum of the penis that we have discussed many times in our classes also, that ulcer will be seen on the shaft or probably on the scrotum, very rarely on the glands, but not on the dorsum of the penis. It will be on the undersurface of the penis very commonly. Okay, it's JAK inhibitor and ankylosing spondylitis. Okay, so whatever. So answer is going to be either tofacitinib, baricitinib, or upadacitinib. That's it. Anyways, fine. So this is a good question. So ulcer will be seen on the dorsum of the penis. This is wrong. This is not a correct answer because ulcer will be seen on the shaft or probably on the scrotum, right? So that's not correct. Okay, JAK inhibitor and ulcerative colitis. Whatever. It doesn't really matter. So ultimately the answer is going to be the same. You know the JAK inhibitors, right? Tofa, upada, and baricitinib. And there is a question that patient had gastrectomy presenting with proprioception and tingling sensation, numbness. Romberg is positive. I mean, this is straightforward B12 deficiency, if I'm not wrong. So this must be quite simple. And I think they've asked a question on copper deficiency. I'm not sure exactly what they've asked, but I think it's very likely to be a Menkes-Kinkies hair syndrome, where the problem will be ATP7A. It is due to defective copper absorption, right? Then they've asked about the sickle mutation. It is the G6V, right? So the valine will be, I mean, the glutamate in sixth position will be replaced by valine. So that's the G6V mutation. So I think they've asked something like that. The most common genetic cause of hypercoagulable state is factor V laden mutation, otherwise called as activated protein C resistance. That's something that we have discussed so many times. Not a feature of psoriatic arthritis. Nail pitting, enthesitis, dactylitis, diarrhea. I'd go for diarrhea. Okay, diarrhea is not a common feature of psoriatic arthritis, right? That's a feature of enteropathic arthritis. That's a good question again. Okay, so not a feature of psoriatic arthritis. Good one. It's diarrhea. Other things are seen, right? Good one, good one. Diarrhea. So medicine is quite simple, straightforward, easy ones. Monoclonal antibody used in ulcerative colitis, vedolizumab. All these things we have discussed already in our QR classes itself, right? So in regular sessions we have discussed, in mission classes we have discussed, in QR we have discussed. Natalizumab and vedolizumab. These are the two monoclonal antibodies that are used in ulcerative colitis. Good one again. So let me write. So what are the monoclonal antibody used in ulcerative colitis? It's vedolizumab, right? Cool. No worries. Okay, lysyl oxidase. Okay, one question on post-CPR management. So what is that post-CPR management? Can you let me know? So is it about targeted temperature management or therapeutic hypothermia, something like that? So talking about post-CPR cardiac, after cardiac arrest. I mean, what is that question about? So let me type that. So now let's vedolizumab. Okay, what is that question? Okay, cool. Okay, hypothermia was there. So what are the other options? Okay, so let me write it over here. I'm not very sure. Post CPR, what is incorrect? All right. MAP at less than 65. Okay, so hypothermia was there. If patient is uncooperative, that's correct. That's a correct statement, actually. The pain is uncooperative, not responding to commands. You have to go for hypothermia. SpO2 more than 94%. MAP more than 65. Intervention required is STEMI. Yeah, that's correct. Revascularization immediately if end STEMI. Okay, I'm not sure. It's STEMI or end STEMI, guys? STEMI or end STEMI? End STEMI, right? If it's end STEMI, this will be the wrong answer. This is not correct. If it's end STEMI, you have to do after some time. That immediate option is wrong. That immediate will not be correct. If it's STEMI, yes, it's immediate. But if it's end STEMI, it's not immediate. It's going to be in the next 24 hours. That will be correct. That will be correct. I mean, that's the wrong option. So that will be the right answer for this. If it's STEMI, then it must be immediate. So what are the other options? Mean arterial pressure more than 65. Okay, it was STEMI. And SpO2 more than 94%. Okay, so I'll come back with the answer for that. I'm not very sure what's going on. Okay, all right, let us move to the other things. So APS type 1, I think there was a question on that. So for that, it's straightforward. Type 1 diabetes is rare. Okay, type 1 diabetes is basically rare. So you don't see type 1 diabetes that often than not. It's more of a feature of APS type 2. Other options in that question was correct. There was a question on meant to be. I'm not sure what. Okay, hypothermia less than 33. There was a statement on hypothermia less than 33 degrees Celsius. Oh my God. Okay, my God. Okay, fine. All right. You cannot go below 33 degrees Celsius, right? So then that will be the right answer. Okay. Hypothermia less than 33 degrees Celsius. Okay, that's bad. This is wrong. This is definitely wrong. Okay. So what was the question on meant to be? What was not seen? Okay, what was not seen? Okay, right? Answer was parathyroid hyperplasia. Correct. Parathyroid problems are not seen in meant to be. That's correct. That will be the answer. So there was a question on NADA's criteria. All right. Okay, I think this is something that we have discussed as well. NADA's criteria. And yes, they have asked about a question on HAGMA, that is high ungap metabolic acidosis, where diarrhea was not the cause. Okay, the answer for that question is diarrhea. It's a simple, straightforward one. And there was an ECG on ARVC, that is arrhythmogenic right ventricular cardiomyopathy with epsilon wave and T wave inversions in V1 to V4. I think that was the answer. And I think there was a question on mechanism of hormone action with regards to insulin, growth hormone, acetylcholine, levothyroxine. Insulin is going to act via the IRS pathway, that is receptor tyrosine kinase, growth hormone via JAK-STAT pathway, acetylcholine ligand-gated ion channels, and levothyroxine is going to be based on your nuclear receptors. There was a question on TTP, if I'm not wrong, so I don't know what exact question was on TTP. I mean, I got some options, but I felt like the thrombosis. You don't see macrovascular thrombosis with TTP, rather you see bleeding in TTP. There could be evidence of microvascular thrombosis, but you don't see the actual thrombus. So I don't know exact question, but you don't see macrovascular thrombosis in TTP. Yeah, this was match the following question, correct. And I think there was a question on name syndrome. They've asked like, what is not seen? These are the things that are seen in name syndrome, by the way. It's a part of Carney complex, where you see nevi, atrial myxoma, myxoid neurofibromas, and ephylletes. So these are the things that are going to see in name syndrome. It's a part of Carney complex. That's correct. I think there was another match the following question on tumor markers. They've asked about catecholamines seen in pheochromocytoma, beta HCG in choriocarcinoma, calcitonin in medullary thyroid cancer, and AFP in hepatocellular carcinoma. Yeah, which of the following is not a component of TTP? Yes, correct. That's thrombosis. Renal failure, thrombosis, microangiopathic hemolytic anemia, thrombocytopenia. That's correct. Thrombosis is not seen in the characteristic TTP pentad. There is microvascular thrombosis, but thrombosis is not a feature of TTP pentad. You won't see that. So I would go for thrombosis as the answer. Renal failure is seen or not? Yes, renal failure is seen in TTP. It's rare, late, but it is seen in TTP. It can be seen in TTP. Why not? Renal failure. In fact, I mean, if you just look at the TTP pentad, there are 5 things: fever, renal failure, microangiopathic hemolytic anemia, thrombocytopenia, and neurological involvement. So these are the classic pentad of findings in patients with thrombotic thrombocytopenic purpura. Okay. And then they've asked about cytochrome C oxidase inhibitor, if I'm not wrong. They've asked about hydrogen sulfide, carbon monoxide cyanide. All of them tend to inhibit your cytochrome C oxidase, but definitely not your nitric oxide. Nitric oxide is not going to inhibit cytochrome C oxidase. And there was a question on antibody in celiac disease. There was a question on antibody. I'm not very sure what question was that. So what antibody was seen in celiac disease? Of course, it's anti-TDG IgA or anti-endomycin antibodies and so on. IgG anti-gliadin. Okay, DQ711. So DQ711 is wrong because celiac disease diagnosis. Okay, DQ2 and DQ8 is what is used in celiac disease, not DQ7 and DQ11. Wrong is DQ7 and DQ11. All right. HLA, DQ7 and 11. Okay, so that's the right answer. What is the safe dose of fosphenytoin? Okay, so was there a question on that? Not sure. Okay, I think there was a question on malaria. Okay, uncomplicated falciparum malaria management. Okay. Uncomplicated malaria treatment. I'll go through that question. I'm not sure what was exactly asked. Okay, I think there was a question on HLA-P27 sacroiliitis and anthreuitis. I don't know what question was that, but there was a question on HLA-B27 sacroiliitis and anthreuitis. You can tell what question was that. And there was a few clinical picture was given. Again, I'm not sure what question was that, but I believe the next step is going to be doing meta-analysis. If you see a clinical picture of FEO, of course, you're going to go for meta-analysis. Drug not used in uncomplicated malaria. You're talking about uncomplicated falciparum malaria, uncomplicated Vivax malaria. So what species was given? Falciparum or Vivax? HLA relation to anthreuitis, it's actually HLA-B27. Obviously. If it's Pesha, it's HLA-B551. If sacroiliitis and anthreuitis, it's going to be HLA-B27. Question was sacroiliitis and not anterioritis. Okay, I'll take off the sacroiliitis, anterioritis part. Sacroiliitis. Okay, all right. So I think there was a question on GBS. Okay, Guillain-Barré syndrome. They've asked about like what you're going to use. You're going to use IVIG or plasma exchange, but definitely not steroids. Have they given IV artesunate or they have just given artesunate? Just leave that question, guys. We'll discuss that later on. But I'm not sure whether they've given IV artesunate or just artesunate. GBS options, albumin-cytological decision, IVIG as first line, areflexia as necessary criteria, plasmapheresis have no role in refractory GBS. They asked which is wrong, right? Okay. Question on GBS. Okay, which was wrong in GBS. Cool. Okay, what was the question on ANA and IFA? These questions I'm not sure. So there was 4 questions. You need to say. I have absolutely no idea. There was a question on ANA via IFA technique. There was a question on pancreatitis. There was a question on tuberous sclerosis, and there was a question on blood transfusion. So what are these questions? If you guys can recall, you can just mention over here. I'll be waiting for another 5 minutes. No worries. ANA pattern. Okay, so it's anti-centromeric, it's crest. Okay, cool. Crest. Okay, so what is the question on pancreatitis, by the way? Okay, there was a question on systemic sclerosis. Lipase more specific than amylase. Yeah, that's correct. That's correct, yeah. Speckled or anti-centromeric. It depends on what type of scleroderma that you're dealing with. Most of the time in exam, they will give crest syndrome. So it's going to be anti-centromeric type. Speckled can be seen if it's anti-SCL70 antibody, but I feel in exam usually will be getting only crest syndrome. The limited form. That's okay, no problem. Patient is in shock and severe pulmonary edema after unknown poisoning. Antidote. Shock with severe pulmonary edema after poison. I need to know the question, guys. It was crest, okay. Limited systemic. So definitely it's anti-centromeric antibody. So this question was the same. Okay, so it is limited cutaneous form of systemic sclerosis. Okay, so anti-centromeric antibody, that's correct. Okay, all right. What is the question on tuberous sclerosis and blood transfusion, by the way? There was a couple of questions, right, on tuberous sclerosis and blood transfusion. Okay, there was a question on B-PAL regime. Nice. Okay. Okay, tuberous sclerosis was match the following type. Okay. That question was about oxygen hemoglobin dissociation curve. Okay. Okay, all right. So I think there are plenty of questions on medicine. I need to get the questions correctly and I have to come out with a good solution. So mostly in the next 1 week's time, we'll be coming up with a good question. I mean, good amount of solutions. So you can look for them in the app. Okay, so with that, let me sign off. I think I'm going to hand over the baton to the next speaker. And if there is any query, you can just always post it in the Cerebellum group or maybe in my Telegram group, Dr. Dilip's MMS. No worries. So I'll be taking up your queries and we'll discuss more. Okay. So I think these are the 32 questions that we can get so far. But I think I assume that there are going to be more questions. There must be at least 50, 55 questions. No worries. Okay. Thank you so much, guys. See you. All the very best. I think who's going to be the next faculty?
Hello, good evening, sir. Good evening, sir.
Hello, sir.
How are you, sir?
I'm good, sir. I'm just searching for the Zoom. Where is the
Yes,
Zoom?
sir. Yes, sir.
Oh,
Thank you so much, sir. I'm going to continue.
Hi, sir.
Hello, sir. Hello, hello. Hope everything is fine.
Sir, everything is absolutely fine, sir. Thank you so much. I mean, I didn't know that you are the next faculty.
No, sir. Thank you. Thank you for your all kind of the love and support. Miss you. And
My love is always there for you, sir, ever.
thank you, sir. Okay, sir.
Okay,
So
guys. Okay. I'll hand over the mic to one of the best faculties that you can ever see for anatomy. That is Srikanth, sir. Please take over, sir. Thank you so much.
thank you,
Thank
sir.
you.
Thank you. Hello, dear students. Hope everything is fine. Audio, video, everything is good from my side. So let's start the anatomy session. Okay. So before starting the session, just one general analysis for all of you that our this anatomy session was you can say not difficult. Yes, it is moderate to easy part. And yes, I want to inform you that all the things we already discussed in our anatomy part, either it is a regular class, and happy to inform you all of you that just right now we complete the Hyderabad champion batch, and all the things are very positively from our anatomy class. So thank you very much for your love and support. And my chat box is also ready. Please inform me. This is the recall session. So the things are please inform me whatever the things, if there are changes, please inform me. I will not take too much time for all of you, but yes, let's start quickly. So again, the magic starts here with our Thor magic. Yes, so let's start the first question. Can you inform me, Uta? Yes, please inform me. There was the one question. Students, inform me the post-intraosseous nerve injury causes. Do you remember the PIN? Always in every class, either the regular class or the offline class, Hyderabad champion batch, I told you all the muscles of the posterior compartment of the forearm, they are supplied by the pin, except a bay. Do you remember Hollywood, Bollywood, Tollywood, all comes from our anatomy, and with the proper three-dimensional orientation, I told you this. That's all. Sir, on the back side, all the muscles supplied by the pin except anconeus, brachioradialis, and extensor carpi radialis longus. Yes, sir. We had seen this all the things in the beautiful three-dimensional way. Here, the posterior compartment muscle. So remember this brachioradialis, brachium to the radius, and our extensor carpi radialis longus. These are crossing the wrist joint. Okay. So that's why loss of supination. No, sir. Because the supination is also caused by the biceps. Yes. Loss of extension at the wrist. These two options. Please inform me, dear students. Yes, very good. Yes, Anjali, only for TV. Yes, very good. Dr. Hamdani, Hyderabad champion badge is here. Miss you all. So these both are exactly same. Can you inform me both we are given? Options are correct or we have to correct anything? So yes, loss of extension at the wrist. No, sir. Because enconius is okay. Brachioradial is okay. Extensor carpi radialis longus. Enconius will not it. But brachioradialis and extensor carpi radialis long, they will cause extension. So definitely this is not the answer. The best single answer will be the A. Yes. Please inform me better. Any correction here? Any correction here? Okay. Fine. Okay, sir. Any correction we need here? Okay. Yes. So we have to come for the next question. Okay. Germ layer derived from the primitive stick. I told you in the embryology, what you have to focus, the pharyngeal apparatus as well as the general embryology part we discussed. So primitive stick. So there are the certain question, there are the confusion. Germ layer derived from primitive stick, 1. Epiblast first migration lead to formation of, yes, 2. And few students are saying that there are the means there is a certain kind of the confusion. What was the exact question, or it will be the 2 or 3 questions also. So if they are asking germ cell layer derived from the primitive stick, the closest answer, the single best answer from the primitive stick, please tell me about the wordings. All correct, no? Okay, okay, Dr. Hamdani. Yes, do you remember Dr. Hamdani, we discussed about the primitive stick is all the point? Okay, yes. So if they are asking the primitive stick, answer will be the mesoderm. Answer will be the mesoderm. Okay, try to understand this part. But few students are saying epiblast first migration leads to formation of. So first germ cell layer which is formed, that is the endoderm. Do you remember? During our session, I told you, sabka malik ek hai. Who? Epiblast. सबका पापा एक है, कौन? Epiblast. Every germ cell layer they are coming from the our epiblast cell. We had seen these images: epiblast, hypoblast, endoderm. So epiblast is making the endoderm. Okay, only for THV. That was not the question. Okay, but okay. Epiblast wala tha. Which this one. So you are saying this one, no? Not this one. So I am marking this was not the question. Am I right, better? Okay, okay. Travel BIT. Only epiblast wala. This one. Neural crystals. Okay, so I am adding the neural crystals. Notochord was in the option or not, better? Yes. Epiblast first migration leads to formation of, you all are right, endoderm. No such question. I think Dr. Lekha, there was the question. Epiblast related question was there. Many students was told. Okay. Neural crystals. Okay. Okay, Dr. Labetalol, you are saying ye nahi tha. Can you inform me, Dr. Labetalol and Lekha, what was the question? Yes, we had seen that the endoderm was making the procaudal plate and yes, epiblast was making the primitive stick. So we had cut this section. Do you remember? The craniocaudal axis was decided by the head end of the baby. If you can recall, give me the heart. If you can recall, give me the heart. Yes. And this is procaudal plate. And then we had seen just opposite to the procaudal plate, the primitive stick, which was dividing right and left half of the body. So we had done the section, sir, epiblast, endoderm, and this our primitive stick was giving rise to the mesoderm. So try to focus what they ask. If they ask that primitive stick gives rise to, the closest answer is the mesoderm. And if you are saying no, sir, no such kind of question, then epiblast is giving which germ cell layer? So epiblast first, it is making the hypoblast and then endoderm. Because hypoblast was not given, so endoderm will be your answer. Okay, thank you, buddy. Thank you, thank you. Okay, cardiac mesoderm was in the option, no? But yes, that will not be the answer. So I am adding the cardiac mesoderm here. Okay, okay. Neural crystal derivative. Yes, yes. Lekha, we will come on that part, no? There was a black and white image of the embryo. Okay, I am adding black and white image. Yes, that is the electron microscopy. Do you remember I told you whenever black and white image, most probably that will be the the electron microscopy. Now, students told me identify the marked structure. So this is the another question. Please tell me in the Telegram group, the students shared such kind of the image. Identify the marked structure. So there was the notochord, primitive stick, neural groove, and one more option. Epiblast thumb migration. Okay, Sonali, thank you, beta. Thank you, thank you. So such kind of the image was there. I think it is not the exact image, but student shared such kind of the image was there. So can you see, sir? There is the one our histological image, pink and blue, pink, blue. That is our histology, normal eosin and hematoxylin. So can you see there is the the central structure, elevated structure, that will be the primitive stick, and the segmented structure. Can you see the segments in this part? Yes, segmented structure. These are the somites. Fine. The primitive streak is opposite to the head pole. Why? Because here is the development of the our, you can say, sir, there was the our notochord. Do you remember such kind of the black and white image? The Dr. Sonali was saying similar kind of the image we practiced. Yes. Can you inform me such kind of the image was there? Ectoderm we had talked. Yes. Mesoderm we talked and endoderm we talked. We had seen the our neural tube just in front, notochord was there, and our beautiful sexy mnemonic was there, LIP, lip, L for lateral plate, I for intermediate, P for paraxial mesoderm. So if you are saying, Dr. Sonali, if you are saying this was there, okay, thank you, Lekha. Okay, please, dear students. So Dr. Lekha, thank you so very much. Yes, it was final. I'm making the star image, no? Okay. Oh, Dr. Swati is saying no, sir. Okay, just I will more confirm. This was actually the INI CET in November 2023. So INI CET is famous to repeat the question. I always told you, repeat the question. But yes, if you will do one mistake, then you are very far from the selection. That's why the different kind of the mindset is required. Okay, sir. So we had discussed this all the things already. Fine. So according to this question, student told and answer was the primitive streak. If any update you want to do correction, please inform me. No. Yes, Dr. PC. No. If not such kind of the question, please inform me, Vita, what was the question? Okay, chick embryo was a different question. I'm adding here. You are saying that chick embryo, separate question. Okay. The left image was in black and white. Okay, sir. This one. Actually, I colored this one. This was the black and white actually, but when I was teaching at our mission classes, yes, Hyderabad champion batch, this all, at that time I colored. That was actually the pink. Okay, okay, sir. Yes, this is the always the most commonly asked question in the anatomy. That is the pterion. Yes, middle meningeal artery. Yes, I told you in the three-dimensional orientation, sir. There is the our talk about the our, yes, this H-shaped area, pterion. Also, I told you the four bones, sir, the frontal, parietal, sphenoid, and the temporal. Another question, middle meningeal artery is there. Rupture results into the our extradural hemorrhage. We had seen these all the things in the question, and I told this question is definitely going to ask. And yes, same thing. The notes from our Hyderabad champion batch, the regular batches, from our mission classes, the bullet train anatomy, the very famous the bullet train anatomy. Yes, this is the radiology integration. So this is the very famous question. Previously in the INI CET, the question had been asked deep to it. There is the stem of the Sylvian sulcus, Sylvian fissure. Okay. Yes, another question in the recent INI CET, just laser me. So same thing they talked. Can you inform me pterion rupture skull image? What were the option? Okay, related to the pterion, not rupture. Okay, so I'm just cutting this one. Energy levels low and fine. Other option, Wernicke's area. Thank you, beta. Wernicke's area. Okay, any more option? Thank you, Dr. Swati. Thank you, beta. Thank you. Option was not on rupture. Okay, so option was not on rupture. Okay, pterion.
जो रात को तो ड्रीमी लगता ही है, दिन में ये उससे भी ज्यादा अच्छा लगता है, फ्लोरल थीम पे बना.
Okay, fine. So pterion rupture, the lateral sulcus will be involved. Wernicke's area is also okay. So if pterion is ruptured, just close to it, Wernicke's area is there, so it may be the answer. But internal carotid artery not. Can you tell me? Related to the pterion, pineal gland, yes. Pineal gland. So pineal gland is also not involved, no? So this is also, so please inform me pineal gland if you are saying pineal gland. So we can include in that situation Wernicke's area can be involved. Pterion rupture, internal carotid artery, it is deep structure, it will not be involved. And pineal gland is posterior side, no? Pineal gland is on the posterior side. Yes, third eye of the Lord Shiva, it will also not involve. So please, we have to look for the option according to it, but it is easy question, exact option we will get, and then we will go, okay? Okay, fine. If you want to opt one option, suppose these all are four correct option. Yes, lateral sulcus of the stem, it will be ruptured, it will be damaged. Okay, Wernicke's area, it may be also affected. Okay, internal carotid artery, deep to it, internal carotid artery. Yes, it may be also affected. Controversial question. Who is wife of Salman Bhoi? None is the answer. Taj Mahal is situated, but Agra is not given. So two are option answer. But one you have to opt, then you can opt the pineal gland, because just deep to it inside within the cavernous sinus internal carotid artery, it may be involved. But yes, till when we are okay. So Dr. Swadhin, what is the structure below the lateral sulcus? Okay, deep to pterion. Okay, deep to pterion. Okay, I will improve. Okay, okay, thank you, Dr. Nitin Razaura. We will improve. Okay, thank you. So these are our different points. So pterion is already expected topic. Okay, next question. Can you inform me what was the question pattern? On X-ray type image-based question of the face, where a branch arising from the external carotid artery. So student inform me about this one. External carotid artery, probably going above the ear near the pterion. Okay. So students shared at the Telegram group such kind of the image, but we are showing the X-ray image. Okay, fine. So here is the pterion and superficial temporal artery is related here. Yes, this is our S-shaped area pterion. Superficial temporal artery is related. Yes, in our all the batches we had drawn such kind of the image. Yes, remember he is not the Johnny Sin. Okay, just one diagrammatic presentation, and we had seen that artery, external carotid artery, it is giving the 8 branches. The first branch, ascending pharyngeal artery, 3 entry branches, superior thyroid, and then there is the inferior labial, and then yes, there is our facial artery. Are you getting? Fine. Now it is having the posterior auricular and the occipital artery, and this artery is divided into superficial temporal and the maxillary. I told you these are the 2 terminal branches. So at the near the pterion, okay, our superficial temporal artery was there. So please inform me posterior view, posterior CT. Okay, I'm adding posterior CT angio. So I will try to put the radiology image. No? Okay, thank you, Dr. PG Godike. Sir, question was which structure lies beneath the pterion? Okay, Milan, I will correct it. Thank you, beta. Thank you for informing. Okay, posterior view. But there was such kind of the question. Okay, and if posterior auricular, is it okay? Middle meningeal artery, fine. So they are asking going above the ear near the pterion, fine. And they are asking about the external carotid artery. So don't mark the middle meningeal. They are asking the external carotid artery. Middle meningeal artery is the branch of the maxillary artery coming from the deep. Okay. So posterior auricular, sir, it is behind the ear. No. Super ophthalmic artery, sir, it is going to the eye. So only one option, superficial temporal. Agree, beta? DSA image. Okay, thank you, beta. Answer, yes, study bistro, beta. Answer in this question according to this option will be superficial temporal. Don't go for the pterion middle meningeal artery because they're asking the external carotid artery branch. Are you getting the twist? This is the INI CET. They will twist now. Agree, beta? Okay, PG Godike, if you are saying the occipital artery, even this is not the answer. Why? Sir, this is our occipital artery which is running behind the ear. Okay. So in this question, they are asking above the ear near the pterion. Yes, above the ear near the pterion. Then superficial temporal artery. If they will say behind the ear, then posterior auricular, or you can go for the occipital artery. Okay. Okay, beta. Just an artery was marked. Okay, thank you for your all the correction. Please inform me all the things. You can DM me at the Dr. Shrikant Verma classes, and please put your all the kind of the correction there also, so I can make the exact recall for all of you. Okay, sir, fine. Move for the next question. Merocrine and holocrine gland. Again, this is the whole already expected question. In every class I am saying this merocrine, holocrine, I am not able to get the option. Please inform me. There was the image or marking, but they given at the Telegram, they put such kind of the image. Yes, during the practice, this is a very old NEET PG question already asked. Sir, we practice such kind of the image whenever there is the empty appearance of the gland. Yes, because when we prepare the slide, we dip the slide into the acetone and alcohol. And do you remember the rule of the chemistry? Like dissolves like dissolves like. So the organic thing, the sebum, sebaceous gland, they are dissolved within the acetone alcohol and they are washed out. So this is giving the empty appearance. So always I taught in the our regular batches, sir, the merocrine gland, the apocrine gland, the holocrine gland. The classical example of the holocrine gland, whole gland is getting destroyed. That is our sebum gland. Agree? Fine. Only image was given and asked what is marked. Okay, fine. So there was the marking only, marking and IBQ. Okay, beta. Okay. So thank you very much. Okay, only image 2. So Dr. Gaurav Ghoshal is saying this was final image. It is actually NEET PG 2012 image, very bad image, but this had been asked, na? But in Telegram, the students share this image. Okay, thank you. Thank you for information. It was posterior view of the DSA. Okay, Dr. Swati, I will see now. Skin, we had corrected this, all the things. We described this, all the our gland pattern in our regular videos, in our offline classes, Hyderabad champion batch, in our ORR, all the session. Na? Okay. So can you tell me, there is the one question. I told you the prostate is very important because the prostate carcinoma, BPH, they are commonly asked. So this time, students are saying, sir, the question from the prostate histology had been asked. Okay. So generally prostate histology was not asked, but this time they asked. So this is the histopathology question. Yes, within the prostate gland is the fibromuscular organ. Yes, within which you will see the pattern and the corpora amylaceae, they are getting deposited. So corpora amylaceae, it was given. Yes. Can you correct which image was there? So these all are the different images of our prostate gland. Yes, here you can see the secretion, the deposition, corpora amylaceae, sir, corpora amylaceae, sir, corpora amylaceae. So this kind of the different kind of pattern was there, and we created all the basics in every session. Please inform me, beta. Image was worse. Hair follicle was not obvious. Okay. Okay, Anushka. Third image. In this question, please inform me. Yes, Satyabrata. Holocrine, apocrine, merocrine, ecrine. Okay, fine. So there was the marking, and they asked the holo, mero. Okay, first image. Thank you, Anjali. Thank you, Mayo. So you all are saying this first image was given. This is the given. These images were not given. Am I right? ऐसा image था. Thank you, study. Thank you to all the dear students who informed me at the Telegram group. Thank you, beta. Thank you, everybody. So okay, so this is the final, na? Okay, and yes, holocrine, merocrine, ecrine. Okay, yes, ecrine, merocrine both are same, na? Ecrine and apocrine. Maybe they given the another option endo, exo to confuse. I am not sure about this day. Okay. Yes, Nitin, no. Water, no, beta. Please inform me. First image of the corporate. Okay. Thank you, Lekha. Thank you, beta. Okay, I'm moving for the next. Sir, there was the question. Not developed from the neural crystals. Yes, lal, wool, neela, wool, anatomy, beautiful. Our magic of the anatomy, the Thor. Yes, the Spider-Man. Yes, the Captain America. Yes, the Batman along with the Captain America. Yes. We talked about all the things with the lots of the fun. So I want to request to you, all the students who had not joined the classes, please come and enjoy the anatomy. So this is the ditto same question which had been asked. The neural crystal derivative. Do you remember? I told you all the concept, and then I told you the one funny mnemonic. Yes, Pits. We are doing disco in front of the Manmohini Mallika. So this was the our derivative, and I told you all the ganglion, they are the derivative of the neural crest cells. Yes, we created the funny mnemonic, we created our different kind of concept, and I told you failure of the migration of the neural crystals due to the loss of the hyaluronic acid activity. It will create the failure of the migration of the neural crystals. This will result into the many diseases like the achalasia, cardiac Hashimoto disease. We integrated with the patho, surgery, medicine, radiology, all. So at that time, yes, we had seen, sir, the retinal pigment, they are derivative of the neuroectoderm. Yes, sir. Ciliary muscle, melanocyte, ciliary ganglion, all are the derivative of the neural crystals. Please inform me if any change in the option or question pattern, beta. Ecrine and merocrine both were separate option. How this INI CET people, they are giving the option? Okay, because both are same. Okay, if you are informing that, so in that situation, I will say, किसने एनाटॉमी का पेपर सेट किया, उसको बुलाया जाए थॉर के सामने में. ये गड़बड़ है. Why? Because these two are same. Merocrine is the ecrine. Do you remember? We remembered the merocrine. मीराबाई अच्छी थी, भगवान श्री कृष्ण के भजन गाया करती थी. Okay, okay, sir. Fine. Okay. Okay, sir. So this question, okay. Yes, again, just recently in the Hyderabad champion batch, yes, primary follicle arrest in which part of the profess one? At that time, this is the previous INI CET. INI CET is famous to repeat the topic. INI CET 2022, this is the spermatogenesis. And right now, yes, I taught in the Hyderabad batch, and always every batch recorded video, the OR, yes, oogenesis, spermatogenesis, one quick review. And at that time, I told you PPD papad. P for profess, P for primary oocyte, D for diplotin. Yes, so here is the first arrest, and the second arrest occur at the metaphase. Okay, sir, same thing. So remember the primary oocyte arrested in the profess one. Getting the point, beta? Okay, and then the second oocyte arrest in the metaphase 2. Khatam, tata, bye bye, gaya. So answer in this question, beta, the answer will be the diplotin. PPD. PPD. P for yes, primary oocyte. P for yes, prophase 1. Prophase 1 is having the phase. Yes. What are the phase? Leptotin, jagotin, pacatin, diplotin, and dikinases. Another is the diakinases. But student inform me about this phase. So answer is the prophase 1. This is the school time question, na? It was different option. Yes, Anjali, SST. Anyone for more the correction, beta? Hope this question is correct pattern. Next, food stuck between cheek and teeth. Please inform me. This was question there or not? Only one student told me this was the question. Only one student told me about this question. Which muscle weakness is associated with it? Yes, it is our Bell's palsy. And I told you the cranial nerve is very important. And the facial nerve is the most important topic. Okay. So we had studied this all with the Priya Prakash warrior. Yes. And we had seen the Bell's palsy also. Yes, NEET PG 2022. So we had seen all kind of the activity. Rhizoris, zygomaticus major, yes, anger muscle, Dharmendra. Basant something like that. All the things we had seen with the proper integration, and we had seen the Bell's palsy, all the feature. I told you during the classes there is a dibbling of the saliva. This all. Why? Because in the Bell's palsy, the buccinator muscle is involved. Do you remember? Yes. Aankh mare, o ladki aankh mare, city bajaye. The Hollywood, Bollywood, Tollywood, all are coming from the anatomy. Yes. Do you remember the orbicus oculi muscle, facial nerve, and this is the winking muscle, aankh marne wali muscle, and yes, whistling muscle, buccinator. In Bell's palsy, the buccinator is involved. So there is an accumulation of the food between the teeth and the cheek, and there is a drooling of the saliva, food, this all. So can you tell me, beta? Can you tell me? Okay, Anand Raj is saying 100% deficiency of the which muscle action causes the problem in the chewing. Okay, can you tell me, beta? Can you tell me the option? Muscles of mastication was not there. Buccinator, yes, according to this, definitely, damn sure, the buccinator, city bajane wali muscle, yes, Hollywood, Bollywood, Tollywood, all are coming from the anatomy. And अर्ज किया है आंख मारे, वो लड़की आंख मारे, सीटी बजाए, और लास्ट में क्या था? ही हो हाँ, ही हो हाँ, ही हो हाँ, हाँ ही हो हाँ. क्या था ये? इमोशन, जज्बात, फीलिंग. हमारे दिल्ली, हैदराबाद और जयपुर के स्टूडेंट्स ने बताया था. सो यस, ऑल थिंग्स आर वेरी इजी बेटा, जस्ट वी हैव टू फोकस अकॉर्डिंग टू द INI CET. Okay, sir. Now come to the next. Yes, this is our radio. Yes, radio, ENT, the medicine, the surgery, the anatomy, also include the patho integration. Yes. Janker's diverticular, nothing. I just recent in the batch the inferior superior constrictor, middle constrictor, inferior constrictor. Inferior constrictor, two parts. Yes, thyropharyngeus, oblique, cricopharyngeus, horizontal, from where there is the outpouching. So can you see this is the outpouching? Yes, Janker's diverticular, beta. Anatomy, ENT, different subject. I think there is no problem, no? Yes, background music is important. Yes, studio. Vishnu, so our students are here. Thank you. Yes, can you inform me, beta? This was the question. Student told me superior orbital fissure was marked and what nerve passes through it. There was some kind of the question, but I'm not aware about the image. I'm not getting the correct option. Okay. Anushka, thank you, beta. Thank you. You are awesome. Thank you, Nitin. Love you all, beta. You all are also awesome. You are awesome. That's why I'm awesome. Fourth option was levator levi superiorus. Okay, beta. Levator. Thank you so much. Levator levi superioris. Do you remember this was our sad muscle? Do you remember we had talked about this one? Nibbi muscle. Nibba was undergriff. Nibbi was sad. So whenever the sad activity, the levator levi superioris. So it is definitely not involved, no? Okay. So we got all the option. Okay, cadaveric image was there. Cavernous sinus was marked. Okay. I think cavernous sinus was different question. No? Okay, I'm just writing just lateral to sella turcica. Or you are saying the cavernous sinus. There was the question, na, cavernous sinus. Yes, this is the separate question. But few students told superior orbital fissure was different. Cavernous sinus 3, 4, 6. Okay. 3, 4, 5, and the 6. Cavernous sinus was marked, na? So thank you, Dr. Swati. Thank you, Dr. Study Bistros, you all. Okay, we will see. Now there was the one other. Yes, this is the question from the, you can say, surgery also. Can you tell me the Pizarro triangle anatomy had been asked? It is actually the all India, you can say, the NEET PG 2019 question, na, surgery. So you all know we have to identify the 3 point. Sir, there is our common bile duct part. Okay. Yes, cystic duct. There is a neck of the our pancreas and junction of the second and third part. Okay. So we have to add this one. This is the most common site of our gastroma. So you can see in the surgery also integrate with the anatomy. Cystic duct. Yes, you are right. Same question, na? Yes. Okay. So hope you. Yes. Can you tell me internal carotid artery turn something like that? Any question was there? Okay. Thank you. Thank you, Harshit. Thank you, beta. Cystic duct was one option. Na? Okay. So I'm putting cystic duct. Any more option, beta? Ask in clinical way. Okay. Clinical way. Thank you. Thank you, PC. Yes. Can you tell me about this internal carotid artery? Yes. Branches of the circle of Willis. There was the one question. Branches of the our circle, and we had seen the magic of the 5. 5 branches of the vertebral artery, 5 branches of the our basilar artery, 5 components of the circle of Willis in a linear pattern, and 5 branches of the internal carotid artery. Any question? Okay. No. Okay, I'm dropping this one. I'm cutting this one. Okay. Okay. Okay, cystic artery. Okay, Dr. Labetalol. Thank you, beta. Thank you. So another option, cystic artery, na? Okay. Okay, so last, identify the cranial nerve. Any such kind of question was there? Students were saying any image. Cranial nerve is very important. Identify the cranial nerve, oculomotor, trochlear, our abducens nerve, and one more thing. Is any such kind of question was there? Cranial nerve, I already told you. Cranial nerve, very, very important topic. No, okay, fine. We are dropping this one also, na? Okay. So we had seen the cranial nerves, every nerve. 1 2 3 4 5 6 7 8 9 10 11 12 13. Yes, in this way we learned the all the arteries. So thank you very much. Please inform if any more thing. My WhatsApp number 91317839495. Please message Cerebellum Academy, your name and any kind of the doubt, any correction. Please inform me. Also, you can find me at the Insta and the YouTube. There also you can comment Dr. Shrikant Verma classes. Please stay tuned and please inform me whatever the correction. Thank you, everybody. Thank you. Hope this session was useful. This is the recall session, so maybe there are the few mistakes. Please inform me. Okay, so thank you very much. I want to hand over to the our next respected sir. Love you all. Gastrointestinal triangle.
Dr. Gaurav is
Hello, Dr. Shrikant.
Sir. Good evening, sir.
Namaskar, namaskar.
Thank
Lal
you,
Phul, Neera Phul, anatomy beautiful. Awesome teaching, awesome.
Thank you, sir.
Thank
Please
you very much.
continue.
Thank you, thank you. Thank you, sir. Thank you very much.
Thank you, sir.
अब आपके बाद हम थोड़ा सा ऑफ था, ड्राई सब्जेक्ट ऑफ था पढ़ाते हैं.
जी सर,
Let
जी
us
सर.
अखियों से गोली मारे.
Right, sir. Right, sir.
ठीक है सर. चलिए, thank you. Hello students, hello. So let me share my screen. Okay, I hope my screen is visible. Okay, so some questions in Aftal. तुसी ना जाओ, अमन अग्रवाल जाना तो सबको पड़ता है एक ना एक दिन. ठीक है ना? So let us one question that Dr. Shrikant has also discussed, derivative of NCC, neurocrest origin. See, this is very, very clear. The answer is retinal pigment epithelium. The fourth choice that Dr. Shrikant has told is melanocytes. We have done this in our classes. Please remember the optic vesicle. And this we have discussed. The optic vesicle which comes from the neuroectoderm. Okay, remember the optic vesicle which comes from the neuroectoderm, it forms like this. Okay, and I've told that the inner layer forms 9 layers of retina, and the outer layer is the outer layer is giving the retinal pigment epithelium. That is why the layers separate. Okay, that is why the chances of detachment is between the inner 9 layers and outer. So neuroectoderm is what is giving rise to the retinal pigment epithelium. This is very, very clear. And also, we remember the mnemonic is crest.
NCC neural crest. This mnemonic we have done. Remember? Okay, crest. Yaad hai crest? Okay, CR is corneal, E endothelium, S stroma, S sclera, T trabecular meshwork, ciliary ganglion, and ciliary muscle. These are all from the neural crest. है ना? याद आया? हाँ, आ रहे हैं. Dr. Sahil, we are coming to macular dystrophy also. But इस question को तो कर ले NCC. So retinal pigment epithelium is coming from the neuroectoderm. It is not coming from the neural crest. Okay, that is very, very clear. One question was on the normal A is to B ratio. Normal question, A is to B ratio. Normal A is to B ratio is 2:3. 2:3, this we have done, where we have done about the AV crossing changes. Yaad hai? AV crossing changes. Salman Khan, Salu sign, coming on the bonnet, carrying a gun. Okay, है ना? वो किया था ना, याद है? आ रहे हैं डॉक्टर साहिल, डॉक्टर अनुष्का, प्लीज डोंट रहेड. वी आर गोइंग टू कम टू दोस क्वेश्चंस आल्सो. पहले इसके चॉइसेस, एनीबॉडी कैन एनीबॉडी गिव मी द चॉइसेस ऑफ दिस? व्हाट आर द चॉइसेस? नॉर्मल A is to B ratio is 2:3. दैट इज नॉर्मल A is to B रेशियो, है ना? हाइपरटेंशन में वी हैव डन, देयर इज arteriolar narrowing. So normal A is to B ratio is 2:3. जो hypertension में in hypertensive patients it tends to become 1:3. This we have done in our class, and 1:3. Okay, so the choices were 2:3, 1:3. The choices were 2:3 A, B 1:3, C somebody is telling 1:5, and 2:5. Okay. So these were the choices. Out of this, the correct answer is going to be normal A ratio is 2:3. Okay, 2:3 is the normal ratio. Okay, correct. Good. So this is what is hypertensive retinopathy, where the arterial narrowing results in changing into 1:3. Normal is 2:3. Correct. Please remember this. Now, this question that you are all talking about, macular corneal opacity. There are three types of corneal opacity: NML, nebular, macular, and leukomatous. Okay. So these are the choices. Were these choices? Iris details not seen, pupil margin not seen, both not seen, both are seen. Was this the correct answers? Were these the choices? Please tell me, were these the choices? Nebular opacity is one which is barely visible opacity. It is a barely visible opacity, and you can see all structures are clearly seen across it. Okay. Macular opacity is a easily visible opacity. Iris is seen, but details are not clear. Iris is seen, but details are not clear. Okay. So iris details are not clearly seen. This is correct. Leukomatous opacity is one where through which you iris and pupil both cannot be visualized. It's a total opacity. Okay, it's a total leukomatous opacity. So this is iris details are not seen. Okay. Anybody having any different choices? Anybody had any different answers? Iris details seen. Okay, so you are saying iris details seen, pupil margin seen, both seen, both not seen. Acha, both seen and both not seen. So then the answer would become pupil margin seen. Then the answer would become pupil margins are seen. Iris detail is not seen through the macular corneal opacity. Okay. Iris details are not seen through the opacity. Okay. So then if these are the choices, then the correct answer would be pupil margin is seen through the macular corneal opacity. Okay. Yes. Is seen. Okay. Let me just write this nicely. It is seen. Correct. Correct. Okay. Is that okay now? Good. So next, moving on to the next question. Okay, so this was the superficial stroma, 1/3 and more than half. More than half of the corneal thickness is your leukoma. This is histopathologically. Okay. This is less than half, and this is absolutely superficial opacity. This is your nebula. Correct? Okay. Yes, only pupil margin seen. Only pupil margin seen would be the correct answer then. No pterygium. Was there a question on pterygium? I've not seen a question on pterygium. Nobody in the group has told me, Dr. Aki. Nobody in the group has told me about any question on pterygium. Okay. Now, one question was where they were given a 34 weeks period of gestation neonate with a leukocoria. On C3 and intraocular calcification is seen. Intraocular calcification, I've told repeatedly, is only seen in retinoblastoma. Only retinoblastoma is a choice where you can get an intraocular calcification. So this is very, very correct. Okay. Can anybody tell me the fourth choice? Was there a fourth choice? There was a question on pterygium. Okay. If somebody can post the question pterygium, pterygium is something that we have done repeatedly in our classes. So if you can tell me what was the question, you can tell me on my WhatsApp number. This is my WhatsApp number. Just text me, whoever can. I have not seen a question on pterygium. Pterygium increase the risk of astigmatism. Yes, that's the correct choice. Pterygium causes astigmatism. This is very clear. This is very, very absolutely clear. Pterygium causes pain, astigmatism. Pterygium does not cause pain. It causes astigmatism. Acha, the fourth choice. Thank you. Thanks a lot, Dr. SSTS. It was Coats disease. Somebody is telling it's a Coats disease was the fourth choice. So this is the mnemonic on leukocoria that we have been doing. So congenital cataract, coloboma, Coats disease, retinoblastoma, ROP. I've already told you ever retinoblastoma is the only one where you will see a calcification. In rest all other, we do not see a intraocular calcification. Okay. Okay. So that was 1 year premature. Okay. 1 year premature neonate. Okay. Okay. So we'll come. I note down the pterygium question later. Pterygium was also a question they are saying. One very interesting question that came. Patient presents with bilateral, sudden onset, painless vision loss. Bilateral, sudden onset, painless vision loss. The choices that I've come across is diabetic retinopathy, iridocyclitis, glaucoma. Glaucoma and iridocyclitis are not painless. They will be having pain as a feature. Okay. And bilateral, unlikely, but diabetic retinopathy will result in a painless sudden vision loss. Why sudden? In case of a patient with a PDR, proliferative diabetic retinopathy, patient can get a vitreous hemorrhage and can develop a bilateral sudden onset vision loss. Okay. Bilateral sudden onset vision loss. Okay, keratoconus was also an option. Okay, keratoconus was also an option. Okay, even in keratoconus, if there is going to be a sudden vision loss, it will be because of high drops. That is sudden swelling of the cornea. But high drops is also a painful condition. It's also a painful condition. Okay, so the correct answer would be congestive glaucoma. Okay, so you are saying this was congestive glaucoma. I'll correct this. This is congestive glaucoma. This is one thing. Keratoconus is one thing. Okay. But the correct answer remains diabetic retinopathy. That is there. Okay. Sudden onset, painless diminution of vision will be, yes, vitreous hemorrhage because of diabetic retinopathy. No doubts in this. Okay. Okay. Congestive glaucoma, or somebody saying an angle closure glaucoma. Both are the same. Okay, that is good. Thank you, Dr. Deepthi, Dr. Surinder. Thank you. Next, this is a question on which I have not been able to get the proper image. They had said, mark the layer of retina. They had given a diagram of the retina most probably, and they had asked the marking of some layer they had asked. Was there a question on this? Was there a question on this? This is a diagram which we have been doing repeatedly, and in every class, whether it is your quick revision, whether it is your marathon series, or it is rapid revision, we have done this diagram repeatedly. I hope you all were able to make this diagram absolutely correct. Okay, so you are saying outer nuclear layer, this is the layer of the nucleus of the rods and cones. Yes, layer of the rods and cones. It was a match the following. Okay, sequence was asked. Sequence was also we remember that there is pigment epithelium, then the rods and cones, then there is a nucleus, then the plexiform, then the inner nuclear layer, then again a plexiform, then ganglion cell layer, then the nerve fiber layer. We have done this repeatedly. This is something that we have done. Okay. Outer nuclear pigment, next plexiform. Acha, okay, they had asked you to there was no diagram there. There was no diagram there. They asked for the sequence. They asked for the sequence of layers. If you are saying this, sequence of layers. No diagram. Okay. So there was no diagram. Thank you for the clarification. Thank you, Dr. Anushka. There was no diagram. Diagram was Dr. Reem Ansari is saying there was a diagram. Okay. So there was a diagram. If you can lay your hands on that diagram from the internet, please let me know. If this was a diagram, then I'm the lucky one. Okay. I'm too lucky then. Label the layer. Diagram and order asked. Diagram and order was asked. Okay. So there was a diagram. Let us hope that some of you can send me the diagram on my WhatsApp number. Again, if somebody is able to tell me, otherwise I'll keep tracing. Okay, sequence was there. Match the following. It was a match the following with diagram. Okay, so match the following. What was in the column A and what was in the column B? Column A and column B? A, B, C, D. Acha, okay. So they had given A, B, C, and D. And the four choices were, sir, same diagram was given. Oh, awesome, awesome. Same diagram was given. Awesome. Yay, I am the lucky one. Good one, good one. Great. That means somebody known to me has set the paper. Okay, and what were the layers that asked? What were the layers they had asked? What was the layer? Pigment. Okay, pigment layer, outer nuclear layer, inner plexiform, ganglion cell. Okay, so pigment layer, outer nuclear layer, then inner plexiform, and ganglion cell layer. Okay, so these were the four choices. Ganglion cell layer. Okay, so they had made this in one of the earlier INI, they had asked only one layer. In this one, they had given you the choices of A, B, C, and D. Okay, A, B, inner nuclear layer, C, ganglion cell layer. Okay, and D, the choice was the inner plexiform, outer nuclear. Inner plexiform, Okay, so they had given an inner plexiform also. Okay, so they had given these 4 layers. Okay. Good. Okay, so this is very clear. I hope you were able to answer this correctly. Okay, one question that you guys are telling me is regarding pterygium. One question that you guys are telling me is regarding pterygium, where they asked regarding pain. There is not going to pain. Astigmatism, yes. Astigmatism is a feature that is there because of the contraction of the muscle. There. Okay, sent on group. Thank you. Thank you, Dr. PC. Okay, what were the other choices? A, B, C, and D. Astigmatism is the correct answer. Pterygium causes astigmatism. That is the correct answer. RP, ONL, IPL, and GCL. Okay. Edema. No, it does not lead to any edema. It does not lead to any edema, Dr. PC. One question on best disease. Investigation choice we all know is electrooculogram, EOG. Okay, there was a question on best disease. Best disease is the only disease where your electrophysiological test, EOG, electrooculogram, it's a electrophysiological test. It is the only disease where EOG is of use. Okay, so that is best disease. Macular edema was another option. Edema, okay, or you can say macular edema. Macular edema. Anybody with the fourth option? Anybody with the fourth option? Doesn't cause pain. Visual disturbance. Visual disturbance. By astigmatism will lead to visual disturbance also. Then this becomes a tricky question. Visual disturbance will also be there. Chemical injury. Okay, they had asked about chemical injury also. There was a question on chemical injury. Visual disturbance. If visual disturbance is also there, then this can also be a correct answer. It will depend upon the language of the question and language of, okay, Dr. Sonali is saying no. Okay, so one question you guys are telling me is on chemical injury. Is on chemical injury. Best step, few hours back. Next step is this. We have done. I have told you that chemical injuries is one topic which has been repeatedly being asked. So injuries is, surprisingly, there was no question on any visual field defects. But visual field defects and injuries, I've been telling you, it is a repeatedly question asked. So chemical injury, we have done this in our marathon series also. The first and most important step is copious irrigation. Copious irrigation for good 30 to 45 minutes. Okay, so no visual disturbance. Now, I also think so that they cannot give visual disturbance. As per me also, this cannot be an option. Okay. Best management is copious irrigation is the first step that has to be done whenever, and it is, if somebody asks, it is going to be for 30 to 45 minutes at least. Okay, and with a solution which is easily available, not a neutralizing solution. Any solution, Inga lactate or normal saline or even plain water can do. Okay. First, take history, copious irrigation. No importance of history. Also, just start washing. Visual acuity. Okay, so one was visual acuity. Second was take history. Do not waste taking time in history. Okay, viscoelastic substance. Viscoelastic substance. No role of any viscoelastic substance, beta. No. Acha, one question on viscoelastic substance. Okay. Okay. What was the question on viscoelastic substance? One question on viscoelastic substance you guys are telling. Viscoelastic substance. That was also one question. Okay, let us see the choices. Use. It is used in cataract surgery. It is used in cataract surgery to maintain the anterior chamber depth. Okay, it is used. Viscoelastic is used in cataract surgery. Yes, it is used to maintain the anterior chamber. Take history also an option. Okay, I've written here, beta. I've written here, take history, but it is not important. You can, as you start irrigation, you can simultaneously take history. Okay, you can simultaneously take history, but otherwise, whatever the chemical, washing has to be done. So ideally, do not waste time in asking the patient. Just start washing and then simultaneously take history. Can be left in eye post surgery. No, it cannot be. Can be left in eye post surgery. No, it cannot be. This is the incorrect answer. Silicone oil. No, silicone oil is not used as a viscoelastic. Perfluropropane नहीं होगा, perfluorocarbon होगा. Perfluorocarbon. No, it is not a perfluorocarbon also. Sulfur. Yes, it is used to maintain during capsulorhexis. Yes, during capsulorhexis. This is a correct answer. During capsulorhexis, this is a correct answer. Yes. Used between anterior chamber and IOL. Okay, no, it is not used between. Okay, if the choices that you are saying here is multi-phasic ERG. Okay, and one you are saying is only ERG, but the correct answer is going to be electrooculogram. Correct answer is going to be EOG. Okay, Dr. PG Godlike 4. Is that okay? Retinoschisis, diabetic retinopathy, one question. Retinoschisis, myopia increases posterior lenticonus. Okay, one question you are saying on diabetic retinopathy. It was a question on diabetic retinopathy. Dr. Anushka, was that a question on diabetic retinopathy? Diabetic retinopathy does not lead to retinoschisis or myopia. It does not increase the posterior lenticonus also. Not seen in diabetic retinopathy. Okay. The not seen in diabetic retinopathy. Not seen in diabetic retinopathy. Dr. Study Bistro. Tractional retinal detachment, TRD. Tractional retinal detachment is seen. Tractional retinal detachment is seen in diabetic retinopathy. Okay, it will be seen. Used to maintain AC during IOL and capsulorhexis. Yes, Dr. Aspiring adrenaline. Which is seen in diabetic progression of myopia. Progression of myopia. Posterior staphyloma. Posterior staphyloma is not seen. Posterior staphyloma is not seen. Retinoschisis. Retinoschisis. Retinoschisis is also not seen, but I would go with the answer posterior staphyloma. It is a option seen in myopia, pathological myopia. But it will increase the risk of tractional detachment. Yes. So the correct language of the question is very, very important here. Okay. On fluorescence angiography, if we seen lot of question was seen. It was seen. So if you are saying which was seen, so it becomes seen in diabetic retinopathy, then traction detachment is the best answer. Traction detachment was the best answer. Not seen. Okay, correct. I have corrected this. So I have seen in diabetic retinopathy. TRD is definitely a complication of diabetic retinopathy. So it will be seen. Correct. Okay. On FFA. So there was a question on FFA also. Okay. on FFA, on fundus fluorescent angiography, microorganisms will be seen. Microorganisms will be seen as hyperfluorescent. Microorganisms will be seen as hyperfluorescent. Okay, beta ji, hyper, because they will leak. So that is why it will give a more fluorescence. So hyperfluorescence will be seen with microorganisms. Correct. Microorganism is seen as hyper. Microorganisms are seen as hyperfluorescent. They would leak the fluorescein dye. This is what we have been telling you in case of a patient with dermatopathy. On FFA, you can see the microorganisms as leaking. Hyper. Seen as hyper. Okay. Dot or branching vessel. Dot. It will be seen as a dot. It will be seen as a dot, not as a branching vessel. Branching vessel will indicate a new vessel. Okay. It will see a new vascularization. So in case of a new vascularization, you will see a branching pattern. Dot. Dot type. Will be seen as dot type, not as a branching vessel type. Will be seen as dot. Correct. So when you are seeing a dot, when you are seeing a branch. Okay. So the correct answer is dot. Dot is the correct answer. Branch is not the correct answer. Branch is not correct answer. Dot hyperfluorescence will be correct answer. Okay. Correct. Good. Thank you, everyone. Thank you for telling me so many more questions. We'll definitely come out with better options and the complete questions in a week's time. Options. So I believe there are options: hyperfluorescence dot, hyperfluorescence branching. Similarly, hypofluorescence dot and hyperfluorescence branching. Okay, I hope there were these 4 options. Correct? Yes. Good. So these were the questions, and I hope you were able to answer. And all the best for your results. My best wishes to all of you. May you succeed. And even if not, then don't worry. This is just an exam. Keep studying. Learning is a lifelong process. Okay, please do not get disheartened. Nobody should get disheartened. Ophthalmologist. Yes, ophtha is a major subject. Okay, आँखियों से, आँखें, eyes are everything. Good. Chalo. I'll hand over the line now to the next faculty. Next faculty, I believe, is Dr. Atul sir.
Namaskar, sir.
Dr. Atul sir are हैं?
Sir, can you hear me? Hello.
Hello. Hi, Dr. Atul sir. You are audible.
I am audible?
Yes, sir. You are audible, sir.
So first of
Welcome.
all,
Good evening, sir.
thanks a lot. I know that you got your hand fractured today, despite that you took a wonderful session. So thanks a lot.
Thank you. Thank you, sir. Thank you very much. And all the best to you, sir. Hand over to you, sir.
Thank you, sir. Thank you. I'm just
Okay.
sharing my screen. Just a second. Okay, is my screen visible? I hope my screen is visible. So 6-7 questions came from forensic medicine, and all the questions were from the PYQs only. Just a second. Yeah, all the questions were from PYQs, but they were asked in a bit unusual manner. Okay, so let's discuss. I think this was a very straightforward question that Marshall's triad is seen in. This is a very, very straightforward. We all know the answer is secondary blast injury. And what is Marshall's triad? It is a triad of multiple small abrasions, lacerations, and contusions all over the body. This is the most common cause of death in bomb blast injury. Okay, multiple small abrasions, lacerations, and contusions are seen all over the body, as you can see in this photograph. Okay, now let's go to the next question. Which of the following is incorrect about heat exhaustion? Loss of thermoregulatory mechanism, orthostatic hypotension is seen, altered consciousness, core body temperature less than 105. So as we know, there are 4 kinds of heat injuries. Number 1, heat cramps is the mildest form, and as we go below, the intensity increases. In heat cramp, there is only cramps plus sweating plus pupil dilation. In heat syncope, there is above plus decrease in BP plus decrease in BP leading to fainting. And in heat exhaustion, there is above plus some increase in body temperature. Heat stroke has a very different features. Heat stroke has a very different features. It has very high body temperature, more than 104 degree Fahrenheit, and there is absence of sweating, okay, and pupillary constriction and mental disturbance. So if you go by this, because in heat stroke, there is actually a complete failure of thermoregulatory mechanism. Thermoregulatory mechanism fails in heat stroke. So now if you go here, loss of thermoregulatory mechanism, no, it occurs in heat stroke, not in heat exhaustion. Hypotension, yes. So please, so hypotension, in fact, hypotension starts occurring from heat syncope itself. Okay, so hypotension will be there. Altered consciousness, this is a tricky step. Actually, altered consciousness is more of a feature of heat stroke, but we have to core body temperature less than 105. This is also correct. So some students would have got confused between this choice, the first one and the third one. But if we have to choose the best possible answer, the best possible answer will be A, loss of thermoregulatory mechanism, which is the classical of heat stroke. Altered consciousness basically occurs in thermoregulatory, but little bit it can occur in heat exhaustion also, like because there is fainting is there, so little bit it can occur in that also. ये examiners में इतनी बुद्धिमानी होनी चाहिए कि कम से कम नॉन एम्बिगुअस चॉइसेस दें, बट अब दिया है, ये ऐसे ही होता आ रहा है, सदियों से ऐसे ही होता रहा, सो कुछ कर नहीं सकते, आपको बेस्ट पॉसिबल आंसर चूज करना है. ये लपड़ झंडू तरह के चॉइसेस आ जाते हैं, इसका कुछ कर नहीं सकते, आने नहीं चाहिए, बट ठीक है. ओके, ऑल्टर्ड कॉन्शियसनेस नॉट सीन वाज द ऑप्शन. अच्छा ठीक है, ऑल्टर्ड कॉन्शियसनेस नॉट सीन वाज द, फिर तो कहानी खत्म, फिर तो कोई दिक्कत नहीं है, फिर तो ठीक है यार, फिर तो एग्जामिनर ठीक है, फिर तो ठीक है, फिर तो उनका शब्द वापस लेता हूं, फिर तो आंसर इज ए, स्ट्रेट फॉरवर्ड आंसर हो गया. ठीक है, चलो नेक्स्ट क्वेश्चन. अ बॉय वेंट टू school and consumed some unknown substance. He came to emergency department with pulmonary edema and silver nitrate test. अब इसका है तो ये PYT में से एल्यूमिनियम फॉस्फाइड इज द डायग्नोसिस, बट सिल्वर नाइट्रेट टेस्ट कोई कॉमनली तो करता नहीं है, सो अननेसेसरी दिस क्वेश्चन वाज आस्क्ड. आई मीन क्वेश्चन इज आस्क्ड व्हिच डज नॉट हैव मच क्लिनिकल रेलेवेंस. So actually what happens is the silver nitrate combines with aluminum phosphide to form silver phosphate, and the silver phosphate is black in color. Silver phosphate is black in color. So if this black color is formed, this gives us the diagnosis of aluminum phosphide. Now aluminum phosphide basically inhibits, it has two mechanisms. It inhibits cytochrome C oxidase and it leads to oxidative stress. Oxidative stress. So basically it affects all body systems. It affects all body systems. So sign and symptoms are very non-specific. A classical sign is there is a very extreme hypotension. Extreme hypotension is there. So main diagnostic feature which is coming here is the silver nitrate test. Now what's the treatment? Now if you ask about the treatment, there is no antidote. There is no antidote. Treatment is mainly supportive. Treatment is mainly supportive, but yes, Some books say that magnesium sulfate can be given in aluminum phosphide poisoning. Why? Because aluminum phosphide poisoning leads to hypomagnesemia. It will correct it. And secondly thing is magnesium sulfate, it competes with the calcium ions, because of which it stabilizes the cell membranes. And stabilization of cell membranes reduces arrhythmias. Stabilization of cell membrane reduces arrhythmias. पर मैं इस क्वेश्चन को कोई बहुत समझदारी वाला क्वेश्चन नहीं कहूंगा, because neither silver nitrate test is commonly done nor magnesium sulfate is like a main treatment. But if it has been asked, so here one thing which is coming is that questions are not coming from rare poisons. Questions are coming from previous year topics only. But in previous year topics, they are going very in depth. They are going so in depth that even if something is not relevant nowadays, they are asking it. तो ये थोड़ा लपट झंडूस वाली बात चल रही है कि क्वेश्चंस आर बीइंग आस्क्ड फ्रॉम पीवाईटी. पीवाईटी इसके एकदम अंदर घुस जाना है, तो छोड़ना नहीं है, बिल्कुल पकड़ के रखना है. जो चाहे काम की चीज नहीं भी है, अगर वो पीवाईटी है, चाहे वो आज क्लिनिकली रेलेवेंट नहीं भी है, even then they are asking it. So magnesium sulfate is the answer. Okay. What is saying? Ball was there instead of okay, ठीक है, so काट देते. Anyhow, ball cannot be the answer. No, British antilucide is a chelating agent. British antilucide will be used for chelating heavy metals. Here the diagnosis is aluminum phosphide. Diagnosis is aluminum phosphide. So whether the choice was ball or protrusion below, the answer will remain magnesium sulfate. क्योंकि otherwise तो इसका वैसे as there is no antidote for aluminum phosphide poisoning, but magnesium sulfate is supposed to have some benefit. ठीक है, अंडरस्टूड. चलो, सब्सटेंस शो, ये भी एक फालतू तरीके से पूछा गया क्वेश्चन है. अ ब्लू कलर सब्सटेंस, दो इट हैज बीन टॉट इन माय क्लासेस दैट कॉपर इज क्लासिकली ब्लू इन कलर, बट ये कोई पूछने का तरीका थोड़ी ना हुआ. There can be hundreds of things which can be blue in color, so ये भी कोई समझदारी वाला क्वेश्चन नहीं था. नंबर वन. एंड सेकेंड थिंग इज historically, if you ask me, what is the treatment of phosphorus poisoning? Now, phosphorus has four. So remember two things: KMNO4 and CuSO4. Both have four. They are used in treatment of phosphorus that I have been teaching you in my classes. Now, but CuSO4 reacts with phosphorus to form cupric phosphide, which is non-toxic. But this was used only historically. Nowadays nobody uses it because copper sulfate itself is a poison. तो ये भी एकदम लपट झंडूस की तरह क्वेश्चन पूछ लिया, कोई मतलब नहीं है. फर्स्ट ऑफ ऑल, they are showing a blue image, or blue image can be hundreds of things, but still they are asking it. So just remember, blue color is classically associated with copper. And for okay, so this is actually copper sulfate, blue vitriol, also called blue vitriol. And then for treatment of phosphorus, it has four. So KMNO4 and CuSO4 the treatments. So answer is phosphorus. So basically they are asking PYTs, but in PYTs they are going into even those things which are not of relevance. चलो भाई, अब कोई जैसे कर रहा है. Which of the following does not inhibit cytochrome C oxidase? So here you remember one thing, that these are the poisons which inhibit cytochrome C oxidase. Cyanide is the classical inhibitor of cytochrome C oxidase. That is the complex 4. Complex 4 in the respiratory chain enzyme. Respiratory chain enzyme. Now, aluminum phosphide, it has two mechanisms. It inhibits cytochrome C oxidase, and it also causes oxidative stress. Hydrogen sulfide, it also inhibits cytochrome C oxidase. And carbon monoxide, the carbon monoxide's main mechanism is formation of carboxyhemoglobin, but it also inhibits cytochrome C oxidase. Okay, additionally it also inhibits cytochrome C oxidase. So here, if you think the answer is nitrous oxide, the nitrous oxide's main mechanism is it deactivates vitamin B12 by oxidizing it. ठीक है? और कोई confusion, कोई समस्या? Please tell me if I'm missing something, because these are all recall questions. Answer is nitrous oxide here. And I think there was one more question on some antidote and drug, where for benzodiazepine, it was flumazenil, classical. For delirium tremens was given. Delirium tremens. For delirium tremens, you will classically use something CNS diazepam, something like that. I think oxazepam was there in the choice. Oxazepam was given in the choice. And then something something on alcohol dependence, etc. I don't remember the exact choices, but something was there. Flumazenil, delirium tremens, oxazepam, and I think for alcohol dependence something was there. I don't have the choices. Okay, and then I think there was some question on chemical injury to eye. Chemical injury to eye. Now here the choices were taking history. ये महालपट झंडूज वाला चॉइसेस दिया गया. दूसरा कॉपियस इरिगेशन विद सेलाइन. और फिर था आईओपी असेसमेंट. दूसरा था शायद विजुअल इक्विटी असेसमेंट. So here also this is a lapad jandus question. Why? Because see, IOP and visual acuity, we know this will not be done. The problem is history taking or copious irrigation. Now this is a very, see, normally somebody can argue if the patient comes, first step is to take history. So somebody can say A is the answer, but then somebody can say chemical injury was also already given the choice. So straight away start giving copious irrigation. So to be very frank, in these kind of lapad jandus questions, we don't know what the lapad jandus examiner would have thought is the answer. He might have considered A as the answer. He might have considered B as the answer. Anything can be the answer. There is nothing like a right answer here. So don't waste your khopda on this. Exam खत्म हुआ है. फालतू क्वेश्चन का, एम्बिगुअस क्वेश्चन का कोई सही आंसर नहीं हो सकता है. दिस नॉनसेंस क्वेश्चंस था, ये नॉनसेंस चॉइसेस था. ठीक है. So anything else? जल्दी खत्म कर दिया फोरेंसिक. Tell me. कुछ और था क्या? Anything I am missing? अरे बोल नहीं रहे हो. Anything else was there? चलो ठीक है, लगता है सब थक गए हो. अब जाओ, एक दो सब्जेक्ट, 3-4 सब्जेक्ट बच रहे हैं. आफ्टर दैट हैव पार्टी, एंजॉय. नाउ आई विल हैंड ओवर दिस टू another faculty, and all the best. God bless you all, and congratulations all of you, whatever the result is, for all your hard work. That itself is success. Thank you.
Thank you, sir. Thank you. So I will take the microbiology recall questions from now onwards. So I guess I am visible, audible. Kindly confirm if I am clearly visible, audible. Write down in the chat box and let me share my screen. Am I clearly visible, audible? Can you write down? Can you write down in the chat box? Let me share my screen meanwhile. I guess you can see my screen also. Everything is visible. So let's start. Okay, so here I will quickly take the microbiology recall. Hopefully you all performed well in the exam today. So here you can see the first question is cold sterilization is all except. You can see the 4 options. Among the 4 options, they are asking which of the following is not a method of cold sterilization. The question is very easy. You can see the 4 options: plasma gas, gamma gas, UV rays, and autoclave. Of course, the correct answer is autoclave. I guess everyone have done this question correctly. It is a very easy question. We all know autoclave is a method of moist heat. It's a method of moist heat. It works on heating principle. It's not cold sterilization. Here we take the temperature 121 degrees, time for 15 minutes, and we take the pressure of 15 pounds per inch square. It works on the principle of pressure cooker. Everyone knows. Coming on the next question quickly. The next question you can see, inoculation loops are commonly sterilized by which method? I guess this is also very easy question. So we got 2 questions from sterilization and disinfection wala chapter. So you can see the 4 options here: autoclave, microwave,
passing over flame 3 times, and heat till red hot. So many students got confused between option C and D, but of course the correct answer is D. So here what we do, we heat. You can see this is the flame. You all can see this is the Bunsen flame, and in the Bunsen flame, we are heating the tip of the inoculation loop till it becomes visibly red hot, because we assume whenever any metal, the inoculation loops are made up of, we know, platinum or nichrome metal. So whenever any metal become red hot in the heat, we assume all the bacteria, virus, fungus, everything get killed at that temperature. So the correct answer is heating till red hot. Okay. The slide is not changing. Can you see the changing of the slide? Okay, just a second. Give me a second to fix it. Let me share my screen again. Now, I guess it should get fixed. You have to give me a minute. I will take this PPT there.
And we can start with Dharma if you want.
No, ma'am. Give me a minute. Just give me a minute. Can you see now it's changing? I guess it should change now, the slides.
Yes, visible, ma'am.
Slides are changing, ma'am. Mukta, ma'am, is it changing?
Yes,
Can you
yes,
see the
yes,
script?
yes, it's
Okay, thank you
changing,
so
ma'am.
much. Thank you. Thank you so much. Thank you. Okay, so we have started this question. I guess you cannot see the question on the screen, so I'm repeating the cold sterilization by all the methods except you can see the 4 options: plasma gas, gamma rays, UV rays, and autoclave. The correct answer, I already told you here, the autoclave. It's a method of moist heat. You can see this is autoclave. It works on the principle of pressure cooker. The temperature I told you 121 degree, time for 15 minutes, and pressure is 15 pounds per inch square. So it's a method of moist heat. It's not cold sterilization. That's why, because they are asking, except the correct answer is D. Okay, so we have already done this question. The second question also I have discussed. So I'm showing you the image now. You can see the second question, inoculation loops are sterilized by which method? The 4 options are in front of you. Is it autoclave, microwave, passing over flame for 3 times, or heat till red hot? So students got confused between option C and D. Some students by confusion, they marked option C, but no, the correct answer here is D, very specific. So here heating till red hot. So here you can see the Bunsen flame. So what we are doing, we are heating the tip of the inoculation loop in the Bunsen flame till it becomes red hot visibly. Because we assume there is a principle that all metals, when they become red hot in heat, all the bacteria, virus, fungus, and parasite present on them, they get killed and it becomes sterilized. So here we are heating it. Okay, and it is a metal made up of platinum or nichrome. The inoculation loop is made up of metal. Okay, so this was the question. The third question is in front of you. You can see test for antibiotic sensitivity. The 4 options are Alex gel precipitation test, E-test. I guess option was E-test. You know the full form of E-test. E-test is epsilometer test. So it is the correct answer. Okay, one option is latex agglutination test and CAM test. So the correct answer is the E-test or epsilometer test. It is a test for antibiotic sensitivity test. Alex gel precipitation test is for testing the toxigenicity of diphtheria. So it's not the correct answer. Latex agglutination test, it's a method of antigen-antibody reaction. It's an agglutination. CAMP is done for GBS, for diagnosing of GBS. So of course, it is not the correct answer. The correct answer is E-test. Here we put a strip, you can see, which is dipped in the antibiotic in different concentration. There is a concentration gradient. So you can see from lower concentration, this is lower concentration, till higher concentration, there is a gradient and we are trying to grow the colonies. So you get a drop shape or elliptical shape. Zone of inhibition. So the minimum inhibitory concentration is where that drop, the tip of that ellipse is joining, intersecting with the strip. So here it's a quantitative method where we are not just testing that particular antibiotic is susceptible or resistant. We can test the minimum inhibitory concentration also. So it's a quantitative method. Okay. So the correct answer is E-test. Okay. The next question in front of you, very easy question. 20-year male pustule rapidly progressed to necrotizing fasciitis. So the first clue given to you is necrotizing fasciitis. The image was not given. Image I have put. Okay. On microscopy, there is a gram-positive cocci. Reading the word gram-positive cocci in chains It is in chains. You can remove the option Staphylococcus because Staphylococcus is in clusters. Okay, in chains, of course, it should be Streptococcus, one of the Streptococcus. And necrotizing fasciitis is typically caused by one of the Streptococcus, that is Streptococcus pyogenes. So the correct answer here is Streptococcus pyogenes. I guess the questions were very easy from microbiology section, isn't it? The next question, of course, again, it's a spotter. It's a very easy question. Mycobacterium tuberculosis typically grow on which media? The image was not provided. I have put the image. So the 4 options, LG media, McConkey agar, SDA. The 4th option, I didn't got it. Can anyone help me in recalling the 4th option? This question will be complete then. Yes, of course, the correct answer is LG media. We know typically Mycobacterium tuberculosis require 8 to 12 weeks. I mean 2 to 3 months for the growth. So we don't wait for starting of the DOTS treatment based on this, but for confirmation, we put the culture. So the selective media is LG media. You can see the green color media. You can see the yellow color, typical cream color colonies on the green media. So this is LG media. Here, one more question come. Usually it is asked that ag we use in this media. Ag is a solidifying medium. It's a solid media which don't contain agar. It's also important question, not asked now, but I'm telling you. So the next question in front of you, you can see there is a gardener. The D option was NNN media. Thank you so much for helping me in recall. Thank you so much. The next, the last option here was NNN. So NNN is Neil, Nicole media. It is for parasites. It is not coming here. Okay. SD is for fungus. McConkey is to differentiate lactose fermenter and non-fermenter for Enterobacteriaceae classification. So of course, it is not the answer. The correct answer is LG media. It was a very easy question. The next question, many clues are given in the question. There is a gardener. The first clue itself is a gardener. Okay. From Himachal Pradesh. The second clue is Himachal Pradesh. There is some disease among the options which is endemic in Himachal Pradesh. So Himachal Pradesh was also a clue. Having multiple ulcerative and nodular lesions on the limbs, maybe on the upper limb or lower limb, it is given or not given, I'm not sure, but multiple ulcers were there. Multiple ulceronodular lesions were there. And axillary lymph nodes were also swelled. And this image was given. Students told me that this image was given. Is it? This image was given in your question paper. So this image typically showing the rosettes. You can see the conidias arranged in rosettes. So what is the correct answer? Of course, no confusion. The correct answer is sporotrichosis. We are talking about lymphocutaneous form of sporotrichosis. So it occurs typically in rose gardener. Although the rose is not mentioned, but gardener is there. And Himachal Pradesh, the disease is endemic. And we can see the rosettes also in the image. Is the image was there? Okay, so the correct answer here is sporotrichosis. The next question in front of you, there is a farmer. Again, the first clue is the farmer. Okay, walking barefoot. So barefoot, again, the second clue. And having some granular yellowish discharge from the sinuses on the foot. So on the foot, multiple sinuses were there from which yellowish granular discharge was there. So what else you want? What else you want? The image was not provided, but in the question, you are having all the clues. The farmer is there, walking barefoot is there, multiple sinuses is there. The sinuses are discharging, having grains in that. Okay, the grains were yellow color. Of course, the correct answer is Madhurella mycetomatous. Okay, so image here, the image was not given. In the last question, this image was given. Okay, so this question was, the other options were nocardia, aspergillus, histoplasma, but it's a typical question. All the clues are given to you, whatever required for diagnosis. The next question also, again, I will say it's very easy, which is waterborne hepatitis. Okay, hepatitis A, B, C, D. So I always teach in my lectures, there are 5 types of hepatitis A, B, C, D. Among them, A and E is waterborne. I mean, the route of transmission is feco-oral. And the remaining 3, they are not shedded in feces. That's why the B, C, D are not transmitted by fecal-oral route. They are transmitted either by parenteral route, most commonly. Second is sexual, and third is vertical. Vertical is from mother to fetus via placenta, transplacental. So the fecal-oral route occurs in A and E. Option don't have hepatitis E. That's why we are going with hepatitis A. It is waterborne. Okay. Sinus discharge was not given. Kaushik. So sinus discharge was not given. So what else information you get in this question? Maybe the sinus discharge is not there in the question. Okay. So what else? You may have some other clue. Na? Farmer was there. Farmer was there or not there? Was there? Farmer barefoot walking was there or not there? And after that, they must give you some other clue also for the diagnosis. Okay. Sinus word was not given. Granules were given. Granular discharge. Granular discharge was there. The granular discharge word was there. If the granular word discharge was also, that's more than sufficient for the diagnosis. Okay, got it? Okay, so the next we have already covered. Okay, So coming on the next question is Ascaris lumbricoids not associated with, or maybe which of the following is false about Ascaris lumbricoids, whatever was the question. So they have given 4 choices. Among them, one of them is not true or false or not associated with Ascaris lumbricoids. We have to pick up that choice. So the first, I don't know the sequence of the options, but one of the option was rectal prolapse. So definitely that is the answer, because rectal prolapse, I typically say and teach in my lecture, it is typically caused by Trichura trichuris. It is not associated with Ascaris lumbricoids. Ascaris lumbricoids causes the diseases of the lung, diseases of the intestine, but not rectal prolapse. It is typically caused by Trichura trichuris. So this is the answer. It is not associated. It is not causing Trichura trichuris. Here, most of the infections are asymptomatic. Yes, it is true. Fertilized unembryonated egg takes some time in the soil so that it get converted into embryonated egg. We know there are 2 types of eggs, fertilized and unfertilized here in Ascaris lumbricoids, and it spread to the lung and it causes asthma-like symptoms. Of course, this is also correct, but rectal prolapse, no, never, it don't cause. So correct answer here is rectal prolapse. The next question is in front of you. Again, there is a farmer. If there is any correction, please let me know. Okay, these all questions are based on the recall. Okay, so if there is any correction, kindly let me know in the question also, in the options also, wherever. Okay, so the next question, there is a farmer presented with chest pain after a blunt trauma. So the history of blunt trauma is given to you. Farmer, first clue is farmer. There is a history of blunt trauma, and after that the chest pain is there. We have taken the pus from the wound and we have cultured it, and this image is given to you. We have done the microscopy, I'm sorry, not culture, microscopy of the pus, and you can see the image. Now in the image, it is not mentioned, but looking at the image, you can identify it's an image of acid fast stain. Can you see it is an acid fast stain? You can see the organism is red color. It is mildly acid fast, and it is branching. So is this image was given? First thing you tell me. Is it image was given or not given? Some students told me the image was given. It was having a branching appearance and mildly acid fast. So if the image is not given, these terms may be mentioned. Mild acid fast organism, mild, not complete. It is partial acid fast. And the second thing, the branching is there. The typical branching is there. Okay. So branching occur in actinomycetes species, that is nocardia. Nocardia is coming in that. So of course, the correct answer is nocardia, whether the image is given or not given. If the image is not given, they may have mentioned the findings in the image, in the text only, or maybe the image is given. In both the scenario, the answer is not going to change. It's nocardia. It's a typical question on nocardia. It's partial acid fast because the concentration of H2SO4 for decolorizing here, we use, how much we use for nocardia? We use 0.5% here for H2SO4. Standard, we use 20%, but here we are using just 0.5% H2SO4 for decolorizing in acid fast stain. That's why we call it mild acid fast or partial acid fast. It is easily decolorized. It don't require 20%, it requires 0.5%. Okay. Okay. Okay, so maybe the image was not given, but they may have mentioned it is weakly acid fast and there is a branching appearance. So the findings of the image are given in the text form. It's okay, but the correct answer here is nocardia. Okay, coming on the next question, all of the following causing urethritis in males except, they're asking except, which of the following is not causing urethritis here. So of course, the most common cause of urethritis in males is gonococcus. Of course, it causes. Trichomonas can also causes urethritis. Okay, Trichomonas vaginalis, it also causes urethritis. Chlamydia can also cause, but Gardnerella don't cause urethritis in males. So the correct answer here will be Gardnerella. Okay, yes. The next question, what is the drug of choice for fasciola hepatica? Now, many students have done a mistake here. It was a little bit tricky question, not much, but there was a little bit tricky question. Fasciola hepatica is one of the trematode. We all know it is one of the trematode. It is a tissue trematode. It is known as liver fluke. We all know that. So for all trematodes, the drug of choice is praziquantel, and praziquantel was one of the options. So I think many students may have marked praziquantel if they don't know the exception. But among the trematodes, only one exception is there, that is fasciola hepatica, where the drug of choice is not praziquantel. The drug of choice is traclabendazole. So the correct answer here is traclabendazole, according to me, if this was the question. If this was exact the question and the options were these. So among the options, if traclabendazole was there, the correct answer is traclabendazole, because it is an exception. For all trematodes, the drug of choice is praziquantel. If apart from fasciola hepatica, any other trematode is asked, like schistosomiasis, like other fasciola busci, or any other trematode is asked, the correct answer would be praziquantel. But here it is an exception. So the correct answer here is A, that is traclabendazole. Okay, got it? Okay. The next question, which of the following is not an example of passive immunity? Very easy question. Okay. The options were toxoid, antitoxin, IgA, antibody, and monoclonal antibodies. So if we are giving ready-made antibodies or ready-made antitoxin, these are passive immunity. But if we are giving toxoid, by the way, what is toxoid? Toxoid is inactive toxin. It is a toxin which is inactivated by formalin. Okay, so it is inactive toxin. So if we are injecting inactive toxin in a human being, the toxin will activate the immunity in that human being. It is inactive. It will not cause the disease. Toxoid is an active toxin. It will not cause it, but it will activate the immunity, the natural immunity in the human being. And so it's an example of active immunity. Toxoid is an example of active immunity. It is not passive. It's common sense, of course. But if we are giving ready-made antitoxin, if someone is injecting ready-made antitoxin, my immunity will not get activated. Ready-made antibodies, any antibodies, natural antibodies, IgA antibodies, or monoclonal antibodies. So if I get ready-made antibodies, my immunity will not get activated. But immunity will get activated if inactive toxin, that is toxoid, is injected. So toxoid is an example of active immunity. So correct answer here will be toxoid. Okay. Question was easy, I guess. Common sense. So most common cause of diarrhea in children. I guess the question was a little bit clinical. They have given the age of the child as 2-year child. 2-year child was having severe diarrhea and dehydration. This was the question, I guess. Okay, I don't know the exact wording, but the crux is that they are asking the most common cause of diarrhea in children. Okay, so of course the correct answer is rotavirus. We all know the most common cause diarrhea here will be Shigella will cause dysentery. It will not be the answer. Okay. So here it is causing severe dehydration in a child we are asking. So the correct answer will be rotavirus. The next question, if there is any correction, please kindly let me know. Please write down. I know I am fast, but here I am discussing just question and answer. You have to cover all 19 subjects. That's fine. Okay. A woman present with malodorous vaginal discharge. Okay. The cervix appeared normal on examination. Cervix is normal. Cervix is normal. And whiff test is positive. Do you have this question in your exam? I mean, with the same findings I have written. So the malodorous discharge is there. Cervix is normal. It cannot be trichomoniasis. In trichomoniasis, there is angry looking vagina. We know. So here cervix and vagina are not normal. Okay. Whiff test is positive. Of course, there is no other choice. The correct answer has to be bacterial vaginosis. The correct answer has to be bacterial vaginosis. Whiff test is positive now. If whiff test is positive, definitely the answer is bacterial vaginosis. If whiff test finding is not given, is this finding given in the question or not? If it is not given, then the question can be tricky and we can rule out other option. But if whiff test is positive, definitely it's a one-liner question. The answer is bacterial vaginosis. Now, was this question there? Whiff test positive was given. I guess you're talking about the same question. The next question, was this question there? The pus swab should be discarded in which dustbin, in which container? In which container? The pus swab, according to biomedical waste management, the latest guideline, 2016 onwards. The latest guidelines, the pus swab we will take in the soiled waste. What do you mean by soiled waste? Any waste which is contaminated with human fluid, any human body fluid, and the linen is contaminated in that. The cotton is contaminated in that. The clothes are, we will call it soil waste. And all the soil waste go for incineration in the yellow dustbin. So here the correct answer will be yellow dustbin. If this question was there, because some students told me this question was there. Yes, of course, the correct answer is yellow dustbin. Okay. The last question here, the match the column. I guess everyone may have done it correctly. Match the column was there. Can you match it? It was a very easy. So donovanosis is caused by what? So of course, the donovanosis is caused by Klebsiella granulomatis. Oroya fever is caused by, it is caused by Bartonella bacilliformis. Okay. Red bite fever is caused by Streptobacillus moniliformis. And Pinta is caused by Treponema caritium. I guess if you can match one or two of them, you can match all of them. So this is the correct match. I guess these were there in the option. Okay. Got it? Got it? Okay. I guess I tried to cover maximum question. The session was informative. Thank you so much. Best wishes for you. Okay. Best wishes for your result. Now I would like to hand over to dermatology. Sir, can you take the session?
Yes,
I'm just stopping my screen share. You can continue. Thank you. All the best.
Thank you so much, Dr. Priyanka ma'am. You have also covered so many questions of the dermatology also.
Okay, is it the case? Sir, you may give better details than me in that case. Thank you so much.
Yes, ma'am. It was more of microbiology. But
Okay.
yeah, I will just.
Yes, sir. There is always overlap between subjects.
Yes, ma'am. Thank you so much, ma'am. So dear students, I am going to share my screen. Just give me a minute. So, dear students, how did you feel the exam was? Did you feel that it was very difficult or it was very easy? So, what were your thoughts regarding the examination? So, I am just watching the volume. So, is the volume okay?
Yes, sir, volume is okay.
Okay, okay. 1 minute. So, I am just sharing my screen. Yes, dear students. So I think there were only very few questions from proper dermatology, and somehow the examiner was very fond of fungal infections. So there were so many questions related to the fungal infection, and most likely we can say deep fungal, that is implantation mycosis. That was the favorite topic of the examiner, I guess. That is the reason why almost 2 to 3 questions came. And also one fungal infection proper question was also asked. That is a topical preparation used for the onychomycosis treatment. So just give me a moment. So I will share my screen. Yes, I hope it is visible. Dear students, please give a confirmation. All the dear students, yes, is my screen visible? Are you able to see the slides along with my video? Yes, I guess it is visible in the live. Yes, okay. So this was the first question, dear student. So was it there in the today's examination? So the onychomycosis. So among the given options, what is the nail lacquer which is used in the treatment? So was this question there? Yes, please give a confirmation yes in the options or like for the video. Dear students, yes, 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 yes. Nail lacquer, was it mentioned or just it was given as topical antifungal which is used in the onychomycosis? So onychomycosis is the fungal infection of the nails. Okay, so in the class we have discussed so many times the topical treatment modality which we are going to use in the case of the fungal infection of the nail. We call it as a nail lacquer. Do you remember this pronunciation we have also discussed? So please remember students, it is the answer here is option B, tababerol. Okay, so this was actually a NEET PG 2020, NEET 2020 previous year question. So this was, so most likely somehow INI CET people have, you know, tried to ask like NEET PG people. Somehow the questions were not so lengthy and not so like clinical questions. They were just like one-liners. Okay, somehow unki atma inme ghus gaye shayad. So it is tababerol. So I hope you all remember cyclopyroxolamine, efinaconazole, amorolfine, tababerol, tioconazole, so terbinafine. These are all the topical antifungals which are useful for the nail fungal infection, that is onychomycosis. So we have discussed this so many times. So these are the nail lacquers or topical preparation. Basically, these are nail polishes. Okay, poshly we call them as nail lacquers. Okay, cyclopyrox, olamine, efinaconazole, amorolfine, and tioconazole, and tababerol, which is a boron derivative. Okay, it will have a boron molecule inside it, and also terbinafine. So I hope you can understand, see it. is the mnemonic with the help of which you can remember all this. So these are all the topical preparations. So you can see here, this is the Tababerol, which is the nail polish which is available. Okay, nail lacquer or topical. Okay, nail lacquer. We'll call it posh. Cyclopyrox and efinaconazole. This we have seen in our class also. And so this question, it was already discussed by Priyanka ma'am. So Himachal Pradesh farmer, gardener, whoever it is, noduloulcerative lesions, if they are there, if the lymph nodes are getting involved and the lesions are getting, spreading from the distal and to the proximal and in a sporotrichoid pattern along the lymph nodes, then we have to think about this sporotrix, okay, protrix, okay, protrix, okay, protrix, okay, protrix, okay, protrix, okay, protrix, okay. Right. Okay. Yes. And this was also discussed by ma'am. So urethritis is caused by all except. So please remember, students, the answer is going to be Gardnerella. The answer is going to be Gardnerella. Right. Okay. So I hope you are able to follow this. And also remember, students, even Trichomonas vaginalis is also associated with urethritis. So it is kept under, it is classified under non-gonococcal urethritis. So this is the next question. So Himachal Pradesh, gardener or a farmer walks barefoot. So what is the infection? So it is, answer is going to be Madurella mystomatis. So if there is any, difference between the options which you have remembered and which you think were not covered, so please put in the comment section whatever options you feel were asked in the actual exam. Okay. And this was also discussed. So foul smelling vaginal discharge, cervix appears normal, which test is positive. So answer is option A, bacterial vaginosis. Okay. So this was the dermatology. So rest of the others were integrated with medicine and also I can say microbiology. So I hope it was, it was a complete discussion related to dermatology. So if you are having any more questions or if you feel any options are wrong, so please put them in the comments. I will just see them and try to make a perfect, complete recall after a few days. Of course, in the app, it is going to be available. Yes, students, are you having any queries related to this? Is it fine or shall we move on to the next subject? If you are having any doubts, please put those doubts in the comment section. I am all eyes on the comments.
Sir,
Yes,
Dr.
students.
Ankur will be good.
Okay. So I will stop sharing. So thank you so much, all the dear students. So Dr. Ankur Jain sir is next to discuss the entire biochemistry. Namaste, sir. Namaste.
Namaste, sir. So, thank you, sir.
Thank you so much. Okay, sir. Thank you so much, students. I'll hand over it to Ankur Jain, sir. Bye-bye.
Thank you, friends. Thank you, sir. Now we come to biochemistry recall. First question. Yes, let me share the screen. First question. Yes, please do suggest any change, any wording change. Yes, phenyl butyrate is given in urea cycle defect for scavenging ammonia. Whenever urea cycle defect is there, ammonia is increased. So in this, yes, in this phenyl butyrate, or few students told that benzoate, sodium benzoate was given. Yes, which one was given? Yes, if phenyl butyrate is given, the answer would be glutamine. And if sodium benzoate is given, the answer would be glycine. Point it out. Tricky questions. Yes, phenyl butyrate is a prodrug. It is converted to phenyl acetate. Then it binds to glutamine. glutamine. Yes. Now it is converted to phenyl acetyl glutamine, which is water soluble and excreted in urine. So if question is yes, phenyl butyrate, the answer is glutamine. But if benzoate, sodium benzoate, yes, benzoate. Yes, if glutamate is there, glutamate bind with ammonia to form glutamine, although they should give glutamine. But if phenyl butyrate is given, either glutamine would be there. If glutamine is not given, you can mark glutamate, but not glycine. But if sodium benzoate is given or benzoate is given, it bind with glycine. Yes. Then it form hippuric acid or hippurate, which is excreted in urine. Both are previously asked question. So in this, I will mark the answer. Yes, phenyl butyrate I have taken. So answer is glutamine. Next question, simple question. You know, tyrosine is normally converted to dopa. Dopa is converted to dopamine. Dopamine is converted to norepinephrine. Norepinephrine converted to epinephrine. This is catecholamines. These are catecholamines. So tyrosine 3, norepinephrine. Tryptophan is converted to serotonin. Serotonin is converted to melatonin. Yes. So precursor for serotonin is tryptophan. Precursor for melatonin is again, yes, tryptophan. Glycine take part in glutathione synthesis. You know, glutathione made up of glutamate. Gluta means glutamate. Thio word is used for SH, cysteine. ONE1, first amino acid is glycine, we usually discuss. So glutathione is a tripeptide made up of glycine, glutamate, and cysteine. Okay. So this is histidine is converted to histamine by simple decarboxylation. You know, glutamate is converted to GABA by simple decarboxylation. Previously asked topic, frequently asked topic. Answer is B, A3, B1. Yes, B1, C2, glutathione, and D4 histidine to histamine. Yes. Which amino acid donate to benzoate? If which donate to benzoate, the answer would be glycine. And which donate to, yes, glutamine. Glutamine donate its amino group, yes, to in the form of phenyl butyrate. Yes. हो सकता है दो क्वेश्चन हो, it may be possibility. Patient had copper deficiency. इसके ऑप्शन बताना प्लीज. Which is required by lysyl oxidase to cross-link the collagen? Simple question, repeat question. Menkes disease, Menkes Kinkes hair disease. M, I remember M like this. Decrease copper. Wilson disease, W, increase copper. Wilson, sun means beta. ATP7B. Menkes disease, ATP7A. We know copper is cofactor for tyrosinase. Copper is cofactor for lysyl oxidase. So if lysyl oxidase is affected, there would be no cross-linking and there would be, yes, collagen defect. They have given deliberately scurvy, you know, vitamin C deficiency, which is responsible for, yes, lysyl hydroxylase. C is required for lysyl hydroxylase. And these two options, ye the ya nahi the? Please do comment. These options were there or not? Yes, the purposes I have taken from this Harper. Yes, lysyl hydroxylase is deficient in kyphoscoliotic Ehlers-Danlos syndrome. So they tried to confuse. If you have read in depth, sometimes you get confused. Yes. So kyphoscoliotic Ehlers-Danlos syndrome, lysyl hydroxylase is deficient. Cysteine was given. Yes, I have taken that cysteine also. Yes, cysteine, glutamate, glycine. It is tripeptide. Yes. Third, next question. Which mutation is seen in sickle cell anemia? Simple, very simple question. Frequently asked. Glutamate to valine. Few students told that one option was yes, valine to glutamate. Yes. I have taken this line from Harper deliberately because whenever we are attempting question, many times we ignore this 2 and 4. So in place of this glutamate to valine at position 6 of beta globin chain, they can give valine for glutamate. Point it out. So 2 and 4, yes, read question carefully. So when question you attempt, read this question, point, yes, sequence at codon 6 of beta changed, resulting in substitution of valine for glutamic acid. Understood? The point is that in exam, we are so preoccupied with the answer, we sometimes mark without thinking. They take from standard textbook these lines, that's why sometimes you get confused. Now, Dr. Sparshar has already discussed medicine also gastrectomy. There is loss of proprioception, tingling sensation, Romberg test positive, B12 deficiency. Previously asked question, you all know that yes, stomach parietal cells secrete intrinsic factor which bind to B12 to form intrinsic factor B12 complex, and that's the way B12 is absorbed. If gastrectomy is there, then intrinsic factor would not be there. B12 deficiency is common. So common cause of B12 deficiency, pernicious anemia, pure veg, gastrectomy, atrophic gastritis, and in this neurological symptoms are there, subacute combined degeneration of spinal cord and demyelination is there. Okay. Now, this question, Sir Sparsh sir has already discussed. Yes, answer is estimation of HbA1c, ED, TA. Clear? Which of the cytochrome C oxidase inhibitor we made mnemonic? IDE. Complex 4, IDE, carbon monoxide, hydrogen sulfide, cyanide. That's why they say, okay, you are making mnemonic, I will give you option nitric oxide. But NO, you know, NO is synthesized from arginine, and it is responsible for, yes, vasodilator, and it is responsible for erection. And anosynthase is inhibited by, I usually say by this platform and by my teaching that never ever smoke. Anosynthase is inhibited by smoking and it can lead to erectile dysfunction. So actor, you know, so many actors are there, or you know, heroes whom you say, they appear to be macho man with cigarette in hand, but they are not macho man because, you know, anosynthase inhibited erectile dysfunction can occur. So ANO is not inhibiting complex 4. Okay. Yes. Next question, Sparsh sir has already discussed X-linked cystic fibrosis, autosomal recessive, Leber's hereditary optic neuropathy. Yes, this is mitochondrial inheritance. Now, this question is very simple. Mnemonic is there. Insulin love lipoprotein lipase. So insulin activate lipoprotein lipase. Insulin hates hormone sensitive lipase inhibit. So in diabetes, insulin resistance, whatever they have given in the question, yes, you will find that insulin will not activate lipoprotein lipase. Insulin is not there, so lipoprotein lipase activity will decrease. So lipoprotein lipase decreased. Okay. And hormone sensitive lipase will not be inhibited, its activity increase. Hormone sensitive lipase activity will be increased. Answer is B. If any modification, you can comment. Although I have tried multiple resources, yes, ask multiple students so that it should be correct recall. Yes, most appropriate. This is the Important question. Most appropriate for diagnosis of chromosomal aneuploidy. Whenever we do genetic testing, molecular diagnostics, cytogenetics, conventional cytogenetics is karyotyping. Yes, point it out. In this, few student told you karyotyping, few student told that cytogenetics, few student told conventional cytogenetics. Okay. Yes. So karyotyping is for chromosomal abbreviation or copy number variation. Where are copy number variation? Trisomy, monosomy, best technique, karyotyping. So cytogenetics are the new technique, or you can say latest, better means faster technique is FISH, fluorescent in situ hybridization. So in question, they had given in situ hybridization, karyotyping, they are used for chromosomal aneuploidy. Definitely they are used. What about other option? This is important. Sanger sequencing. You can do nucleotide sequence, diagnose change in nucleotide sequence by Sanger sequencing. We can detect trisomy, means aneuploidy, with the help of next generation sequencing. We can by next generation, not Sanger sequencing. In the same way, we can detect aneuploidy by digital PCR, but they are not commonly used, or most appropriate if they have asked, I will, yes, conventional cytogenetics. Okay, so conventional cytogenetics is karyotyping, in situ hybridization. So if they have asked most appropriate, definitely I will go with, yes, second and third. Clear? Any doubt? This is simple question. Isomerase is not used in recombinant DNA technology or genetic engineering. Phosphatase or alkaline phosphatase, dephosphatase 5 end of RNA DNA, remove terminal phosphate from either 5 end or 3 ends. Okay. Terminal transferase, add nucleotide to 3 end of DNA. Restriction nuclease we use. So this, yes, we can say this is used. CRISPR-Cas9 is for DNA editing. Yes, this is used in recombinant DNA technology. Answer is isomerase. Okay. In this, I will prefer to go with second and third, most appropriate. So thank you. All the best. Take care.
Thank you, sir. I guess we should conclude the session. Other faculties are not available.
Okay.
Yeah. Thank you so much, sir.
Thank you, friends. पॉजिटिव रहना, लास्ट में एंजॉय करो 1-2 दिन बस. थैंक यू.
Shubham, I guess we should end the session.